Hi everyone, hi and welcome to this webinar event delivered by RSTMH, Royal Society of Tropical Medicine and Hygiene, in partnership with Sightsavers. For those of you that don't know me, I'm Tamar Ghosh, I'm the Chief Exec of RSTMH and here to welcome you to this incredible event that we have over the next 4 hours. So this is a chance to really showcase the key findings of ASCEND Western Central African Programme, which has recently been published in a supplement, RSTMH's International Health Peer-Reviewed Supplement. And this is a great opportunity to talk about the outcomes and the learnings of the programme and think about next steps. So this is part of a partnership that we have with Sightsavers to try and use all of our channels, our journals and other channels to really showcase the work that's happening in our sector. And we're really proud to be a part of this partnership and able to bring a great deal of that to you today. So we have 4 hours together, as I mentioned. We're going to start with hearing from Sightsavers, who delivered ASCEND Western Central Africa along with their consortium partners. We'll then hear from the UK's Foreign, Commonwealth and Development Office, FCDO, who were funders of the programme. And then we're going to have 4 panels where we'll pick up different perspectives of the programme and have some debates with some incredible panellists talking about those issues. At the end of the time, we'll have a final panel where we'll just bring together all that we've heard and think about what the lessons are for next steps. Now, 4 hours is quite long, we recognise that. There are a couple of breaks for you along the way to make sure that you can grab water or drink or have relief. So hopefully you'll be able to stay with us till the very end, and that final panel I think will be really exciting. Okay, a bit of housekeeping before we start. If you have questions, and I'm sure you will throughout the webinar this afternoon or this evening, depending on where you are, please do use the Q&A box, which you can find at the bottom of your screen, hopefully. And that's the way that you can post questions along all of these talks and the panel discussions. And we'll be gathering some of those questions and trying to bring them to the panel members where time allows. So do put any in that you would like to ask. Please join us on social media. We'll be tracking the conversation today using the hashtag AscendProgram, and that will soon be in the chat, so you'll be able to see that. And we'll be recording today. You probably saw that when you joined, and there'll be a recording that we can circulate after the event. So just to let you know that we'll be recording. And the last thing to mention is that we've got incredible speakers this afternoon, and many of them. If we were to talk about everything that they've all been doing, it would take us the whole afternoon. So full bios will be posted in the Q&A for you to see. When we introduce our speakers, we'll just be introducing their current title and organisation, that's all, and name, and you can read much more about them in the Q&A. All right, so we're gonna move along then, and I'm really delighted now to be introducing Simon Bush. Simon is the Director of NTDs at Sightsavers and also President-elect of RSTMH. So Simon, over to you.
Tamar, thank you very much, and good afternoon everyone, or good morning to those who are joining earlier in the day. This is a new approach for Sightsavers in disseminating our learning from a programme, and forms the second of 3 supplements in the journal International Health. And this is part of an agreement that Sightsavers has with RSTMH spanning 3 years. The supplement that we're focusing on today features COVID-19 adaptation work around leaving no one behind, equity and beneficiary feedback, also work around strengthening health systems, achieving those elimination dossiers as well. So it's so right that these feature as part of the panels of this session that we're holding today. We're holding this event to celebrate the success and the impact of the ASCEND West and Central Africa programme, and to ensure that the tools and the learnings from that programme are of benefit to the wider NTD community. Of course, there remains a critical need for further support to achieve global NTD elimination goals and to fill funding gaps. But this event is a chance to highlight some successes and also issues and challenges from the implementation of the programme. We well know that the UK's flagship programme to eliminate neglected tropical diseases unlocked more than £12 of resources for every £1 of UK aid invested. And this is highlighted in one of the papers that formed part of the supplement. This effectively turned £53.4 million from the UK taxpayer into £706 million worth of support. The papers highlight success from the programme, including supporting river blindness elimination in 3 states of Nigeria, improving treatment for refugees and internally displaced people in the region, building national and regional health system resilience, and the capacity to control and eliminate NTDs, and even preventing the spread of COVID-19 through various behaviour change programmes. We spoke in the editorial of the papers that eliminating neglected tropical diseases is a relay race, and we can't afford to drop the baton with countries so close to the finish line. This remains so true. The fight against NTDs hasn't stopped with Ascend closing. While Sightsavers and partners continue the work and try to secure new funding, we must also recognise, celebrate and learn from what was achieved thanks to UK aid. This summer, the UK government signed the Kigali Declaration, renewing their pledge to end the scourge of neglected tropical diseases. Those of us fighting to beat NTDs, particularly those based in the UK, were encouraged by this commitment and look forward to work with FCDO to see where NTDs fit in with the strategies on global health that are being developed. Finally, putting together the special supplement was a considerable amount of work for so many people, authors, editors, reviewers, and so many more. That hard work has produced a set of papers which I think we can all be very proud of. Thank you to everyone involved. Back to you, Tamer.
Thanks, Simon. And I'm delighted now to welcome Dr. Eleanor Schmidt, who is Director of Evidence Research and Innovations at Sightsavers, to say a few more words about the programme. Thanks, Eleanor.
Thank you. Thank you. Good afternoon, good morning, and welcome to the launch of our special supplement. We at Sightsavers have always been very strong advocates of rigorous evidence and evidence-informed programmatic decision-making. For us, evidence is very central to our programs and is very critical to make sure that our programs are not only effective and efficient, but also that they are responsive to the needs on the ground and responsive to the changes that we see on the ground. We have also been very, very strong advocates of the role that implementing NGOs can play in advancing the global research agenda and in generating evidence through their programmatic data and through implementation research that is built in their programs. In the past 10 years, we have made very significant investment in building our own internal research capacity. And we have always encouraged other NGOs to publish their data, to publish their findings from the programs, and to debate them through international scientific fora. And this special supplement is a very good example of this approach. In the supplement, you will find articles which are based on our operational research, on the analysis of our programmatic data, and very importantly, some learnings, programmatic learnings, which are based on observations and reflections of program managers and people who implemented their SEND program on the ground. And I would like to thank the RSTMH for the collaboration and for this opportunity for us to publish this special supplement. And many thanks to all the authors who contributed their time and shared their very useful, very valuable insights and learnings from the program. And I really hope you will enjoy reading this supplement. Thank you.
Thank you so much, and lovely to hear from Eleanor and Simon about the supplements. Okay, so now we're going to hear from UK's Foreign Commonwealth and Development Office, FCDO, and we have two speakers. Firstly, Laura Westcott, who's Deputy Head of the Health Institutions and Health Security Department there. And then afterwards, Dave McConalogue, who is Consultant in Public Health and currently Health Advisor with FCDO. So Laura, I'm going to pass to you first.
Great, thank you. And just to say, we're going to do a bit of a double act here, so we'll pass between us as we go. I hope that doesn't confuse things. So just as a little bit of an introduction from me, first of all, I'd just like to say that from the outset, really, of the Ascend programme, the learning was really embedded right from the beginning, and we really saw the commitment of Sightsavers and other consortium members to that. So it's really positive to now see the supplement, and we really welcome the opportunity to engage with the event today. In terms of our presentation, we're going to give a little bit of an overview of how we incorporated health system strengthening into the Ascend programme and our thinking behind that. And then we'll go on to some lessons that came out of that, many of which chime with the points in the relevant article from the supplement. And then we'll go on to a little bit of reflection about health system strengthening efforts more widely and NTD programming. So I'm going to actually hand over to Dave for the first slide, and if you could move on to that would be great. Thanks.
Hi, so I mean, it's really great to be here. I do actually, if people can spot it, I've got my video on. For some reason, the camera's not working, so apologies. But it's really great to be back here in the Ascend programme, considering where it all started, and amazing to see the achievements that have been made in this period of time. So what we wanted to do was, just before we really sort of crack into what happened in Ascend, is just to remind you what our thinking was around integrating health system strengthening into a vertical, what was essentially a vertical disease program, and the reasoning is as true today as it was back then. So I think the first thing is really about the health system is the gateway for access for people. People don't access a health system with a particular disease in mind. They access the health system with a problem. For example, people don't come to a doctor with telling them they've got TB. They come to a health post telling them that they've got a cough, night sweats, losing weight, etc. And so it's a great advantage to have that. And if you've got a really strong health system with great coverage and access, actually you can mop up a lot of things. Also, people don't come with normally one problem, they come with multiple problems. And it's better to deal with the person as a whole rather than as an individual disease. It's also true to say, despite massive success in terms of the elimination agenda, and Ascend has really pushed that forward, and we've seen successes on the program already. Actually, this is a long game, and we need to find approaches which are sustainable into the long term and which aren't just depending on a particular donor's or several donors' funding cycles. And the health system is the strongest way to do that, with the government at the helm really driving that forward. So that actually, when the money gets pulled back, we don't lose that momentum entirely, and we've got a base that we're already built on. I think also it's true to say that health system interventions are really cost effective. Now the studies around cost effectiveness of health system strengthening are imperfect, but actually they're generally all very, very positive. The issue that we have as well, and we really recognise this, is sometimes the added value is not felt directly into that disease that the program is focused on. And so we have to do some thinking about as well about that value and that balance between the disease we're focusing on and the actual health benefit to the population that we're serving. It's also true to say that we find, and everyone will recognise this, the inefficiency of running parallel systems. And we see this across multiple interventions and multiple aspects of this system. For example, surveillance and monitoring, which is an area that the Ascend programme looked at and had a large impact in, and I can think of that in Nigeria. But actually we have multiple sets of disease surveillance and response. So we have really great systems for particularly for malaria and HIV, but then the actual overriding integrated disease surveillance and response system in the country might be the real weak link in that. And that's problematic and ineffective. And then I think the last one, which goes without saying, I think, and is through all of these points, is we really wanted to build a legacy that beyond the program and beyond that funding cycle, and something that would endure both for the diseases that we were focused on, but also for the wider health system. Let me pass back to Laura.
Thank you. So a little bit on the Ascend programme and our thinking and the lessons that came out of that. So we started off when we were designing the programme with the ambition to kind of really have quite a step change in approach when it came to health system strengthening within the programme. And so I mean, there'd certainly been aspects of system strengthening in previous NTD programmes, but we really wanted to kind of increase the focus on health system strengthening and take more of a kind of structured approach where we wanted to, you know, consider each of the health system building blocks and what would health system strengthening within an NTD programme mean against each of those building blocks. We had quite a lot of discussion at the business case development stage around, you know, what would be the scope of this within the programme. And, you know, there is that classic kind of trade-off between sort of investing in some of the interventions that we did do under the programme and that our partners implemented, and you know, the kind of investment in immediate service delivery as well, and you know, a recognition that there was a kind of limit in terms of scope as to what an NTD programme could do in terms of the wider health system. And so we focused in on sustainable delivery of NTD control and elimination activities, and the health system strengthening activities of the programme really kind of focused in on things that could make the most impact in that sense. And we kind of piloted this levels of implementation tool where we really tried to articulate what would health system strengthening look like against each of the building blocks, and in particular with the aim of sustainable systems to deliver on NTD interventions in mind. And you know, be interesting to hear any reflections from others as to whether that was useful. Going on to the next slide, there was a number of lessons in the programme completion review around the health system strengthening work. And as I said earlier, a lot of these do chime with what's in the supplement as well. And these were lessons from the full Ascend programme, which also covered East Africa and South Asia as well. And across the full programme, you know, we took this kind of systematic approach. So in terms of some of the key lessons that came out of the review, the fact that HSS and integration are long-term goals, and this came out strongly in the supplement as well. So working with ministries of health to prioritise activities, to understand barriers to integration of NTD efforts with wider health systems, and to really try and kind of foster that ownership, I guess, through particularly through NTD master plans, but also just through that engagement as well. One of the things that proved challenging in the programme was monitoring and evaluating those health system strengthening efforts, and a lesson to kind of really consider that from the outset. I think in terms of, you know, being able to articulate what's being achieved, and where we're trying to get to within the span of the programme, and then being able to hopefully embed that within longer term country-led plans. There is also kind of lessons, more specific lessons around what it makes sense to integrate, and some examples of things beyond mass drug administration where there was successful integration with the wider health system around data, for example. And then lastly, and I know this will come up in a later section, There was lessons around the successful pivot of the programme to support the COVID-19 response, and what that could mean in terms of what NTD programmes can contribute to wider health systems and community-based interventions. Going on to the next slide, and kind of turning things around a little bit in terms of, you know, where are we now, and health system strengthening efforts more widely. So the first thing I would say is that, you know, a lot of the lessons here and a lot of the thinking around what's next aligns really well with the NTD roadmap, with WHO's sustainability framework. And I know actually the efforts of the Ascend programme also help to feed into those, and to develop guidance for NTD master plans as well. And so, you know, thinking about, okay, there are broader health system strengthening efforts, but there are also health system strengthening efforts within other disease programmes. And how can NTD programmes align with this? So there's a lot of emerging evidence. Many of you, I'm sure, will have seen the FCDO approach paper, which really aims to outline how health system strengthening is an approach, and it's embedded across all of our work, rather than being a kind of standalone programme, if you like. And then there's a lot of emerging evidence as well around what works for health system strengthening, which could really help to inform how NTD efforts can integrate with those broader health system strengthening efforts as well. So, for example, you know, being part of discussions around UHC and essential services and financing, and also considering what NTD programmes can bring to these efforts. So, you know, there's examples, you know, really rich examples of that from the programme around, for example, the COVID-19 Flex, lessons around community health workers and drug distributors, and the reach of NTD programmes and the successes of the programmes in terms of leaving no one behind. So the conclusion, I would say, you know, from all of that is that there are definitely ways that the NTD programmes can integrate with those broader health system strengthening efforts, and a lot that NTD programmes can bring to the table in that sense as well. And I'm going to hand back now to Dave. Thanks.
Thanks, Laura. So I was just going to do a few kind of concluding remarks around some of the reflections on the challenges around integrating the HSS and the health system strengthening approach into these specific programs. What I would say is that this isn't unique to Ascend. Actually, these are challenges that we're having also with some of the other really big GHR, the global health initiatives, particularly for me, working with the Global Fund, but also with Gavi, the Global Financing Facility, and others, and the reflections will be part of this. In fact, I think Ascend really maybe started on this journey in some ways later than like Global Fund, but actually the progress and the approach, I think was far more accelerated than I've seen in other areas. And you know, my feeling is there's a lot of learning from what happened in Ascend that we can take into the global health initiatives and our approach with them. But the key thing for us, and for me in particular, is when we started on this journey, is it was very clear, very obvious that we're all in pretty new territory here. It wasn't that any of us hadn't worked on health system strengthening. I think all of us, of course, commissioners and implementers had, but actually in terms of really how to outline, how to integrate it, that was new territory for us. And Laura talked about the levels of implementation tool. That was really a tool twofold. One, it was to really try and work with the Sightsavers and Crown agents on what we really meant by this this integration approach, and to agree what the integration approach was. But it was also for us to really sort of lay out what we really meant by it, so we really understood it and could use that in terms of then evaluation, monitoring, and understanding whether actually it was going to be a success. One of the key areas that we really struggled with, and we struggle with it in the Global Fund as well, is are we paying lip service to health system strengthening? So you could probably take any intervention which has got a health implication, which broadly sits within a health system, and say that you've strengthened the health system. And so we had to think about what was the litmus test for that? What really was health system strengthening? And that, in a way, talks about the levels of implementation. So this isn't a binary thing. It's health system strengthening. It's not health system strengthening. Some of them are really expansive and really have a massive impact well outside the health outcomes for that particular disease, and others will be focused very much on delivery of that intervention, but hopefully in a way at the minimum which is sustainable, or at least doesn't harm the wider health system or detract from it. I think the other thing we really struggled with, and we struggle with this in the Global Fund massively, is the disease-specific targets and the actual sustainable change to the health system strengthening component. And part of that reason, I think, is two. One, often making a sustainable change to the health system takes a longer time and is more difficult to track. But also, many of the organisations who are working with Global Fund, Gavi, Ascend, will have really strong targets related to detection, prevention, and treatment of those specific diseases. And missing those targets is very easy to measure, and will have a big impact and be a big conversation at board level. And so we really had to think hard about this. And the problem is, and I think it's still true today, is that the disease markers normally trump the health system strengthening markers. And I think the learning from Ascend is really useful in terms of how we frame that well beyond Ascend. And we're having conversations with Global Fund and others about getting the metrics much clearer for around health system strengthening, so that we can really present that case at board level and beyond. Some of the other elements we have is really trying to make the health system strengthening an operational reality in disease-specific programs is really difficult, actually. And again, the problems at Ascend are problems that other disease-specific programs will have. The key one for me is that we can't do it in isolation. Government has to be at the centre of it. We have to build behind a government plan, and we have to be aligned and coordinated. And we need some tools to do that. And so things like resource mobilisation and tracking to make sure that we understand what each other are doing and we're able to coordinate effectively and openly is really important. We need to look beyond disease-specific interventions. We need to look at what implications the wider health system and a way to track those. And we need to really be able to measure the impact of those so we can sell those stories back as well. The other thing is it requires new relationships and different ways of working. And we have to accept that and stand back and look at that. And so we need some new stakeholder mapping and some new relationship building. And that's different in each country as well. So there's a global level, but there's also the country level. And it must also not sit as a standalone entity. It's one thing to have a health system strengthening program, but it can't be set as a parallel health system strengthening program. And that's not as uncommon as you might feel. So I've come across it in Nigeria, where we've got different entities doing health system strengthening programs beyond the specific disease, but they're doing them in isolation. And potentially, so one through a government organisation and one, and that really undermines the whole purpose of it. The main thing for me to take home from this was Ascend achieved lots of things, and it really broke down a lot of barriers and moved it forward. And one of the things I really like is that you're getting the evidence out there, but we have to do a lot more of that. We really have to tell the good stories about how taking this approach really had an impact at the personal level. So really telling good case studies really telling good stories through case studies. Back to you, Laura.
I think we've already run over time, and that was a good conclusion. So I'll pass back across. Thank you.
Lovely, thank you. Thanks, Laura. Thanks, Dave, for that. And we've posted in the chat another, I know you had it before, but a link through to that position paper from FCJO if you want to have a look at it. Okay, so I'm going to pass back to Simon. Tell us a bit more about the Ascend programme itself. Simon, thank you.
Thank you very much indeed. And I hope that this session puts into context the sort of overall objectives of the project and the successes of the project, and then allows us to move into those more detailed discussion of the papers. If you could show the first slide, please. Just to set the scene, really, the programme timeline, the project actually started in April 2019 and ran right through to the 31st of August 2021. It was financially supported by the UK Foreign Commonwealth and Development Office, and for the section that covered West Africa and Central Africa was a total budget of £53.4 million. It was a consortium-based programme. Sightsavers was the consortium lead, the contract lead, working with the Liverpool School of Tropical Medicine, the Schistosomiasis Control Initiative Foundation, Mott MacDonald, Accenture Development Partnerships, and also MNC Saatchi World Services. Of course, there were a large number of sub-national partners implementing the programme at country level. HANS, based in Nigeria, Helen Keller International, Mitosaf, again in Nigeria, OPC, covering work in Chad, and the United Front Against River Blindness, covering work in the DRC. The programme featured focused on the 5 PCTs. Key activities of the programme included the behaviour change campaigns, strengthening the national health system, as was outlined before, and supporting various types of NTD surveys, as well as the usual interventions of an NTD programme covering mass drug administration and surgeries. Next slide, please. The milestones of the project are highlighted in the papers. We're very proud, I think, as the project partners, that 12 implementation units in Nigeria met the criteria to stop lymphatic filariasis, mass drug administration. 16.3 million people no longer require treatment for at least one NTD. And I think this will become a metric in an NTD programs, which we need to concentrate on. Those people who no longer require treatment and have moved over into perhaps what is post-treatment surveillance. Various national mechanisms have been supported in WASH programs, NTD coordination established between those WASH programs and NTD programs. And 9 countries implemented mass drug administration with an amazing quarter of 1 billion treatments that were delivered over the life of the project. If you could go back to the previous slide. Thank you. The project delivered TT surgeries for trachoma and also hydrocele surgeries as part of an integrated LF program. Over 1 million community drug distributors, teachers, surgeons, case finders, patients and carers were trained as part of the program. An amazing cadre of staff and volunteers. And very quickly, the Ascend program flexed to the global pandemic that we all faced. A large part of this program was implemented during the COVID-19 pandemic. And we estimate through the work that had been produced in association with MNC Saatchi and other partners, that 137 million people were reached with behaviour change campaigns. And there's some fantastic examples of these that you can see online at the Sightsavers website. Next slide, please. Just putting that into context, you can see the cases of surgery in case of trachoma and hydrocele surgeries that were covered in multiple countries as part of the Ascend program. Next slide. And there's the mass drug administration treatment numbers that I spoke about, and you'll see that the graph splits those treatments between LF, onco, schisto, soil transmitted helminths, and trachoma. Post Ascend, the project has now closed, as we know, and across country programs, Chad, Guinea-Bissau, Liberia, and Nigeria, Sightsavers has obtained funding through a variety of other funders, and are able to support the distribution of an estimated 31 million treatments. And further across the portfolio of the Ascend countries, which including DRC and Ghana, we have also managed to this year continued that process and covering 92 million treatments across the range of the PCT NTDs. Next slide. The reason for this session is really to present the learning and success and the challenges of Ascend. The program was incredibly challenging. It all seems very easy when you show those treatment figures, you show those great success in surgeries. But at each stage of the program, there are various challenges, and particularly the COVID-19 element of the program. And so we're presenting this to hopefully accelerate the elimination and control of neglected tropical diseases in the current context. And just as I finish, I wanted to thank very much the consortium members who are all represented on the call today. In particular, I'd like to acknowledge members of the project's executive group, Sean Freer, Diane Northway and Wendy Harrison, who over the life of the project I very much enjoyed working with, to David Molyneux, who was the chair of our consultative technical committee, to my colleagues from Sightsavers and our coalition partners. There are so many that I could run over time, so I dare not start a long list of names and organizations. But I think just to say a big thank you, and I think we can all be very proud as to what was achieved as part of the project. And thanks also to FCDO for funding the program and giving confidence to our coalition and consortium to implement. And with that, Tamar, back to you.
Thank you so much, Simon, and agreed, I'm sure we are all very proud of what's been achieved by Ascend with Sightsavers and the consortium partners. Okay, so we're going to move to our first panel, and I'm going to introduce for this Dr. Maria Rebola Polo, who leads the global program for elimination of onchocerciasis at WHO. Maria, over to you.
Thank you, Tamar. And it's really a great pleasure to be here and almost emotional to see so many colleagues from FCDO and Ascend, Laura, Delna, all friends, and we have been together on this for a long time. So thank you for having me. This important panel is going to be looking at the support to achieve the elimination dossiers, as we were told. And we have two important papers. The first one focuses on the support to achieve the dossier through strengthening health systems with assessments on hydrocele surgery services. And the second one is looking at the interruption of transmission of onchocerciasis in 3 states in Nigeria. For that, we have 5 distinguished panelists. The first one is Hanan Betts, co-author of the hydrocele surgery paper, Susie Madaki from Sightsavers Nigeria, who is co-author of the onco paper, Nkue Nekua Mpo, National Entity Coordinator for Benin, and Michael Igbe, former Federal Ministry of Health Nigeria, also co-author of the onco paper, and Son Freyer from LSTMH. So I pass the floor to our first author for the first paper.
Hi, as you introduced, I'm Hannah, and I worked at LSTM both on Ascend and in the program that LSTM did before Ascend, which is actually where this particular journey started. So we developed and rolled out a hydrocele surgery facility assessment tool, which sounds very wordy, for the elimination of lymphatic filariasis. Next slide, please. So the background, obviously, everybody knows about the global program to eliminate LF in 2000. And as part of this, it was required for the dossier to provide an essential package of care for MMDP. This includes access to lymphedema services and hydrocele surgery, and also evidencing the readiness and quality of both of those services. So the requirement for the dossier is to submit 10% of facilities assessed as a minimum requirement, and we looked to develop a tool to assist in this process for hydrocele surgeries. There was already a tool provided by the WHO to assess lymphedema services, and we really developed this as a companion piece to allow a similar process to be done. It's to assess the preparedness of the health system to deliver services as part of routine care, and looking back at the previous talks, really an emphasis on the health system strengthening role of that. Next slide, please. To show you the full timeline, we worked in a number of countries on the previous grant before Ascend, and in 2018, as part of this, we started to develop the tool, which was based on 2 WHO documents, primarily the SARA, or SARA, I'm not sure how you say it, SARA, and also surgical guidelines that provided for hydrocele surgery. So we combined those 2 things together to produce a tool which could be used, and also which had the capacity to be further adapted for individual country requirements, especially if they had additional requirements on top of the WHO ones, and that was done in 2018. That was piloted in Bangladesh, Nepal, and Malawi, which were the countries we were working in at that time. We got feedback from that. There were also some updated guidelines provided at a similar time, which we integrated in with that. So there was some editing in 2019. And then there was a full rollout into a number of Ascend countries, which I can't remember the full list, but included DRC and Sierra Leone and Ghana, and some others as well. So if we can move on to the next slide. So there is a requirement for 10% of facilities to be assessed, but through discussions with the various countries, it was decided that actually through the rollout and also through the pilot, they were going to, all of the countries we dealt with decided to utilize it in all of the facilities that they used for hydrocele surgery as a way of healthening the health system there. So in total, 9 countries, 14 community facilities, 75 district hospitals, and 12 regional or national hospitals. And it had a very positive response too, but hopefully there'll be more discussion of that during the discussion after this. So the suggested process is, first of all, data is collected on site using an electronic data capture. That this produces an individual report for each health facility, but also the aim is to pull those in together to make a summary report. These should be reviewed in detail with national and sub-national stakeholders. I'm going to get onto the subject of why that is a little later. And then the development of a national quality improvement plan by the MOH, owned by the MOH, and submitted as part of the LF elimination dossier. So if we can move on to the next slide. So the HSFAT itself includes a number of different domains, including, I'm not going to go through the full list, but it includes background information, which is not assessed at all, it's just information about the facility, amenities and emergency patient transfer, training, laboratory capacity, availability of equipment, practice and infection prevention. And importantly, each of these domains is not necessarily answered by the same person. It's answered by people in the facility with the capacity to know the answers. So there are some suggested informants there on the right-hand side. There are a number of key indicators for each of these domains, and also a number of supporting indicators, because this isn't a box ticking exercise of pass, fail, or getting a particular score. It's a tool to allow countries' Ministry of Health to see areas where things are prepared and things where more preparation might be useful. So we didn't want to get into a thing where you get X, you get 50 points out of 60 points and therefore you've passed, because that's not a valuable way of moving forward with strengthening the facilities. If we could move on to the next slide. So at a facility level, there is one domain which has a pass or fail criteria, which is the availability of running water. And one facility did actually fail that, but that was one facility in one country, and it was decided that it was not possible to improve that situation, so that facility was not included. But other domains, local expert knowledge and the supporting indicators provided the context, as I say, not a pass-fail situation. For instance, in one country, syringes were not on site that were on the list, but other appropriate alternatives were available and that wasn't deemed a problem. In one country, I believe it was Nepal, there was no on-site laboratory capacity in a number of the facilities, but testing was available in nearby clinics, and it wasn't going to be something that impinged on the ability of the facility to do the work, which really shows the importance of that local assessment of the assessments, rather than simply saying it has passed, it's failed, because obviously in a different country that may have been more of an issue. Broader actions were taken as well. For instance, in Malawi, there was some training that was conducted, and a supervision assessment process was developed in response to the summary report for the assessment in Malawi. In Niger, there was training. Protocols were supplied to all of the facilities, and also they were looking at the stock management and supply chain. In Benin, facilities were provided with a standard operating procedure and surgical safety checklists, which were shown to not be available in all facilities. And there was also some surgeon training. So you can see there that there was a variety of different actions, all about trying to strengthen the health system and make the facilities more prepared for hydrocele surgery. If we can move on to the next slide. So the aim of the HSFAT was that it was a tool for the countries themselves. And so we made it as usable and transferable to other people's systems as possible. So it is available in both French and English. And it's in an Excel format, which can be used in ODK, COBO, and SDK, which I believe are systems that most of the countries that were part of Ascend are familiar with and have the capacity to utilize. It's also adaptable, for instance, use of local administrative areas or addition of local requirements that may be specific to the country. And we supply it as is, it is available as is to any countries that want to make use of it. And they can take that away and make use of it as they wish. The next step, which we haven't really got through to very much, because obviously the end of Ascend happened maybe slightly earlier than we would have hoped. It could be made available on other platforms, and it could possibly be integrated into the WHO tools if the WHO felt that that would be appropriate. And we're open to anyone else who wants to make any suggestions on how it might be useful to a broader range of countries in the future. I don't know how I'm doing for time, but that's all really I have to say.
Thank you, Hannah. Yes, we are running a little bit out of time, but that was really impressive. Thank you so much. And before I pass it to Susie, I want to remind the audience to please use the questions and answer feature that is down in the Zoom panel to post any comments, any questions, and we will use them through the panel discussion after the presentation of the papers. So please, Susie, back to you now.
Good morning, good afternoon, and good evening, everyone. The second paper is titled The Interruption of Transmission of Onchocerciasis in Kaduna, Kebbi, and Zamfara states in Nigeria, another milestone achievement. Next slide, please. Onchocerciasis caused by the filarial worm Onchocerca volvulus is transmitted by Simulium black flies, also Simulium species, also called black flies. This is one of the 5 preventive chemotherapy entities that's targeted for MDAs in Nigeria. Now, as a disease that's targeted for interruption of transmission by WHO, The main strategy for interruption is through a community-based drug distribution of ivermectin. And the program has 3 phases. First, corresponding to the lifespan of the adult worm, which is 12 to 15 years, MDAs are supposed to be implemented with at least 80% therapeutic coverage, after which post-treatment surveillance for 3 to 5 years will be done. And lastly, the post-elimination surveillance as the last phase of implementation. Next slide, please. Now, the journey to the milestone achievement in Kaduna, Kebbi, and Zamfara states took us through 19, 20, and 21 years of MDAs in Kebbi, Zamfara, and Kaduna states. These MDAs achieved 65% epidemiological coverage. They were implemented for at least the number of years that I just mentioned. Now, all of these were in accordance with the WHO guideline. To stop MDAs after such a long time, the WHO guidelines were consulted, and the WHO guidelines suggest that an effectivity rate of less than 1 per 2,000 black flies determined by PCR in black flies, and a seroprevalence of less than 0.1% in serology in children less than 10 years old should be achieved. And so entomological and epidemiological assessments to determine the stop MDA was done. And in these, children aged 5 to 9 years old in these states were dried blood spots were collected from children within the age range in the 3 states. And then entomological assessments were also done by collection of black flies through major means. That's the human landing capture, and then the use of Esperanza window traps. And the black flies were tested for O150 PCR Onchocerciasis volvulus, and then the dried blood spots were tested for the oncospecific IgG, that's the OV16. Next slide, please, the results. Now, results from the dried blood spots collected from 9,708 children in the 3 states were all negative, and 6,139 black flies were collected in Kaduna. There were much fewer flies in Kebbi and Zamfara states, 129 and 2 respectively. And all of the black flies collected were negative, despite massive person hours of black fly catching in Kebbi and Zamfara states, which took all year long, cutting across 2 rainy seasons. The black fly catch was really low. Additional intensive breeding site prospection was also done in Kebbi and Zamfara states. Next slide, please. Now, the results in our study meet the WHO threshold of a seroprevalence of less than 0.1% in children, an infectivity rate of less than 1 per 2,000 infectivity rate in black flies. This shows the transmission has been interrupted in all 3 states. The Federal Ministry of Health approved the stopping of MDA in the 3 states. Consequently, 2.2 million people in Kaduna State and 4 million people in Kebbi State no longer in need of mass drug administration of ivermectin against onchocerciasis. Next slide, please. Post-treatment surveillance is now recommended in the 3 states. However, in all 9 state LGAs in Kebbi and all 6 LGAs in Zamfara State, and then 13 out of the 16 LGAs in Kaduna State, LF is also endemic in those places. And so MDAs with ivermectin targeting LF treatment will continue in these places, because after the treatment against LF ends in these places, that the post-treatment surveillance period will begin. And after which a post-treatment surveillance period of 3 to 5 years will be done. And then the confirmation will be done to determine if the transmission of onchocerciasis in these zones have been interrupted. That will be done by entomological assessment using the 0150 PCR full screen test, and if necessary, additional serological testing to determine that MDA could stop. Now, this milestone achievement of stopping onchocerciasis treatment in these 3 states in Nigeria is a step towards realizing the target set for onco elimination in the 2021 to 2030 NTD roadmap. Happy to be able to achieve that here in Nigeria. Thank you very much.
Fantastic. Thank you so much, Susie. Congratulations really for the impressive work and nice paper. So I am going to just start us with some few questions for the panelists before we go to the questions and answers that the different attendees have written in the chat. So first, I want to address the first one to Hanan, because, you know, as countries are reaching elimination of lymphatic filariasis, one of the challenges they actually face in the putting together the dossier is actually having enough information on morbidity management and disability prevention. So this tool seems to be a really practical tool to address that. How has the digitalization of the tool helped with the standardization, the data management, and also with the potential integration with the WHO existing tools?
I think the digitization of the information always helps with the speed of getting things back, which is hugely important, especially when you're dealing with large countries. And we were able to look at and start the assessment process almost instantly, sort of the next day, which I think is hugely important. From a standardization point of view, I think it's invaluable because some of these are quite complex questions, and having them on paper, there's always the opportunity for different interpretations. There's always the opportunity to potentially leave things out. And being able to create a summary across an entire district or an entire country, which is standardized across that, really helps with that development of a plan that is appropriate for strengthening the system within that entire area. And I think also people find it easy to use as well. It's easy for people are very familiar with using tablets, people are very familiar with using phones, and you don't have the major issue of data transposing data, writing it up, double entry, all of that. So it's a lot more efficient and less error prone as a whole. I'm definitely a fan of electronic data collection.
Absolutely. Docteur un peu, est-ce que vous pouvez nous partager l'expérience de Bénin et comment le pays a trouvé l'utile à niveau national, comment a-t-il aidé les programmes, s'il vous plaît, Docteur Impo? Je pense qu'on ne peut pas vous entendre encore.
Merci beaucoup.
Oui.
Est-ce que vous m'entendez maintenant?
Oui.
Ok. Je voudrais vous remercier pour m'avoir invité à cette rencontre très importante. Merci aux panélistes qui sont également invités à découvrir tout à l'heure les provenances et les fonctions qu'exercent donc les différentes éminentes personnes qui ont été invitées. Je voudrais donc saluer l'initiative qui est en cours aujourd'hui. Je dis qu'elle va certainement faire leçon ou école pour les autres pays qui n'ont pas encore franchi cette étape-là. Il faut reconnaître que le Bénin s'est inscrit dans l'élimination de la filariose lymphatique au problème de santé publique. Donc, de ce fait, a mis en œuvre les stratégies recommandées par l'OMS et nous avons abouti à l'interruption de la transmission de la filariose lymphatique dans toutes les communes. Chez nous, Bénin, communes, c'est district. Toutes les communes donc au Bénin qui étaient endémiques étaient au nombre de 48. Nous avons interrompu la transmission et par conséquent arrêt de traitement de masse. Alors il fallait donc faire face à la gestion de la morbidité liée à la filariose lymphatique dans tout le pays. Ce n'est plus les communes endémiques, mais toutes les communes au Bénin, parce que l'endémicité par rapport aux complications, ça peut se retrouver partout. Donc on a eu la chance d'avoir un projet pilote dénommé ANESVAT, dont le siège est à Bilbao, en Espagne. En Espagne, pardon. Bien, c'est bien ça. Donc, nous avons eu un projet pilote qui pourrait durer un peu plus de 18 mois. Au cours de ce projet, il était question donc de prendre en charge la morbidité liée à la filariose lymphatique et de prévenir des incapacités éventuelles par rapport qui seraient liées à cette maladie. Donc, le projet a été élaboré et à la mise en œuvre au cours des réunions du comité de pilotage. Donc, on s'est rendu compte qu'on ne pouvait pas mettre en œuvre la chirurgie après le recensement des cas suspects, mettre en œuvre la chirurgie dans les hôpitaux identifiés à l'époque pour affecter les camps sans les avoir évalués. Et de ce fait, donc, nous avons dit que c'était très important. Et qu'est-ce qu'on devait aller collecter comme information? Nous avons donc, au regard des informations utilisées par-ci et par-là, nous avons payé que nous avons utilisé sur le terrain pour faire l'évaluation des hôpitaux qui devaient abriter les camps. Je ne sais pas si vous me comprenez, je peux continuer?
Merci, ça a été très, très important, mais je pense qu'on doit passer à la prochaine question, mais c'était vraiment bien de connaître toute l'expérience de Benin et comment c'est utile à contribuer à mettre ensemble toutes les données de morbidité de la filariose lymphatique. Merci. We are going to pass now to some free air, because this tool really seems to have a potential of impacting programs beyond lymphatic filariasis and being used to strengthen health systems. And what are your lessons learned from the development of the tools that can be broadened to other areas? What can we take forward?
Thanks, Maria. The tool was developed to support countries, particularly around initially compiling their elimination dossier, for instance, but it was also very much around supporting countries to identify where resources needed to be focused. So it was not, it wasn't a quality assessment, it wasn't an assessment of the quality of those facilities, but the next step we anticipated would be that countries could use the assessment tool against those domains within it to identify areas to address quality beyond hydrocele surgery, but looking at areas such as infection prevention, basic equipment. These were all areas that the health system would benefit from knowing the profile of the facilities within a district, within a province. So whilst there were certain questions that specifically related to NTDs and to hydrocele, it was, as we said, based on the SARA tool, but it was also, the vision was that it could be used then by countries to address areas around quality, but that would have been a country-led, country-owned process, but something that they could use that assessment to do.
Absolutely. Thank you. And we are moving now to the second paper. We are lucky to have Mike from the program in Nigeria. And now that the MDA has stopped in all these areas, can you talk to us a little bit about the post-treatment surveillance activities that are planned and how you are coordinating with the other neighboring districts and also with the lymphatic filariasis program?
Okay, thank you very much. Because onchocerciasis is co-endemic with lymphatic filariasis, full programmatic surveillance has not commenced. But what we have done so far is to communicate with the communities, letting them know why treatment has stopped, which has to do with the good epidemiological and entomological results that were obtained from the evaluation that was carried out in the 3 states. At the moment, we are doing a research, and it is titled, it is a research on surveillance in Kaduna State specifically. The results or whatever we are going to obtain from that research will be taken into the full programmatic surveillance when the treatment for lymphatic filariasis stopped. From what we have been told in the paper that was presented, onco is endemic with LF in 13 districts in Kaduna State, and we have only 3 districts that are onco only. Then if you look at Zamfara State, all the 6 districts are co-endemic with LF. Then in Kebbi, all the 9 districts are co-endemic with LF. And that is why full programmatic surveillance has not commenced. Then by the time we're able to eliminate LF and the treatment for LF stops, then what we have in mind to do is that we are going to sensitize the communities again on the surveillance that will be carried out. And for those communities that are at the border with other states, we are going to hold cross-border meetings to sensitize them on the surveillance. And then those health posts that are also at those border communities will be used for treatment of the immigrants that are coming from other states to these states where we have eliminated onchocerciasis. But if you look at the issue of recrudescence, these 3 states are not at serious risks of recrudescence. If you look at the northern part of the 3 states, we have Sokoto and Katsina State. They are hypoendemic for onchocerciasis. So they are not posing any serious threats on these 3 states. Then if you look at FCT and Kano, when skin snip was taken from these 2 states, the results were very good. And then we classified them as they are on track for elimination of onchocerciasis. And then the NOEC gave them a yellow color. So they are not really of a threat to these 3 states. Then if you look at other states, for instance, we have also Plateau and Nasarawa at the southern part of these 3 states. They have already eliminated onchocerciasis. Then if you look at Bauchi and Niger, they're yellow. So these states are not really posing any serious threat in terms of recrudescence. So
Thank you.
Yes.
Thank you so much, Mike. That was really helpful. We are going to close this panel with the last question from our audience, from the attendees, that is going to be to Susie. And this is about, they are interested in knowing the difficulties you faced in collecting the black flies in Kebbi and Zamfara. What difficulties did you face and how did you overcome them? Because this can be very relevant for other countries as well as they do their entomological studies. Thank you.
Thank you very much, Maria. That was really a difficult one, trying to catch black flies in Zamfara and Kebbi states. First, we tried to do that during the one rainy season, but the black flies were just not there. And so the National Onchocerciasis Elimination Committee recommended that a whole year of black fly catching should be done. So between August 2019 and July 2020, black fly traps through 2 means really, the human landing capture and then the Esperanza window traps were done. Still, at the end of that whole 1 year of catching, only 129 black flies were caught in Kebbi and only 2 in Zamfara State. And so the man hours for effort put into catching the black flies were used to compute the annual transmission potential and the annual biting rates. And thankfully, the no black flies mean it's an ATP of 0. And then still, the impacts of it had been done in Kaduna also when few black flies were recorded. And because of that, we were seeing that the black flies are really not there. The effort that has been put into it has been documented. And other studies have also warned that possibly we could have that dearth of black flies. Bakke et al. In 2018 warned that with changing climate, with changing river levels and so many other climate change conditions could affect the number of black flies that are caught at any time. And so that is something that other programs should note, that in trying to catch black flies, the number of black flies may just not be met, because the WHO criteria is to catch 6,000 black flies, and you really might not be able to get that. The difficulties are there, possibly for any reason. Thank you.
Thank you so much. On move encore à l'expérience de Bénin. Docteur Mpo, est-ce que vous pouvez nous partager encore de votre expérience dans l'utilisation de cet outil et comment vous pensez que vous pouvez partager cette expérience avec les autres pays dans l'avenir?
L'utilisation de cet outil au Bénin a été très utile. En ce sens, ça nous a permis vraiment d'avoir dans les hôpitaux de 4 départements une idée réelle avant les campagnes de la capacité des hôpitaux à offrir ou à abriter les camps. Donc, avant de réaliser les campagnes de chirurgie, avec Assemble, on a vraiment eu, avec le projet Assemble, on a eu un outil très, très bien structuré, à l'issue duquel on a vraiment des indicateurs ou des informations qui sont très importantes à régler avant donc, les camps. Et sous outil, je pense que s'il y a je devais conseiller aux pays qui n'ont pas encore réalisé cette activité, avant vraiment les campagnes, il faut évaluer et avoir la capacité des hôpitaux d'offrir le minimum de conditions pour pouvoir réaliser, abriter les camps de chirurgie. Ça nous a permis de régler d'avance un certain nombre de dispositions, certaines dispositions à prendre ont été donc réglées avant de réaliser les campagnes de chirurgie dans les bonnes conditions. Voilà ce que je vais ajouter par rapport
Thank you. Maybe I can translate. Peut-être je vais traduire un peu à l'audience pour qu'il puisse aussi comprendre votre parole, ceux qui ne parlent pas le français. So he was really saying that he recommends all the program managers that before they do these campaigns, they actually utilize this tool to be able to assess their capacity and to improve the capacity of the different centers before they actually put the resources of doing the actual campaign. So he finds this very helpful, and he thinks this tool will help in the future other countries as they move to do their hydrocell surgery campaigns to assess their capacity before the campaigns. So merci encore, Dr. Mpo. So we are running out of time, so we are going to finish this panel by passing the floor to Dr. David Molyneux, who is raising his hand and also want to make a question or comment. David.
Thank you, Maria. Just a quick one. In reference to the situation about the numbers of black flies one can catch, I heard, and it was at the Sightsavers meeting, that the river systems in Zamfara and Kano, when they were about 15 years ago or more, flowing permanently during the dry season, now are completely dry. And the same applies, as I understand it, to areas in Burkina and Cote d'Ivoire, where rivers which flowed permanently during the dry season are now completely dry and so can't allow black flies to breed and stay over the dry season. I don't know what that's the case. So essentially, it's about desertification and climate change.
Thank you so much, David, for sharing that. So I hope you enjoyed this wonderful panel. I think we learned a lot and really reflects how amazing the ASCEM program has been. Back to you, Tamar.
Sorry. Thank you so much, Maria. Thank you to all our panelists. It's great that we've got these glimpses into the papers, and there are some fantastic papers within the supplement. We've put a link in the chat there to the supplement, so you can go right in and have a look at it. We've now got a break, and we're going to take just 5 minutes. I hope that's all right. Just time to have a bit of time away from the screen, grab some water, whatever you need. We'll be back in exactly 5 minutes, and we will start promptly. So thank you to everyone who's spoken so far, and see you in 5 minutes. Thank you. There. Thank you so much for coming back. Okay, so we've now got our second panel of 4, and this is on taking forward lessons from COVID-19. So to introduce you now to the moderator for this one, it's Simon Lee, who leads on policy for malaria, TB and NTDs within the Global Health Directorate in the FCDO. Simon, over to you.
Yeah, so welcome to our second panel today on taking forward the lessons from COVID-19. The session draws on 2 papers published in the Ascend supplement, and I think we're hoping to achieve 3 things from the session: an understanding of the response to the challenge of implementing NTD activities safely during a pandemic, an understanding of how NTD programs fitted within the broader landscape of the COVID-19 response, and an understanding of the main lessons to take forward. So the way the session will run is I'll shortly hand over to 3 of the paper's authors to summarise the papers. We'll then have a discussion amongst the panel and then open the floor to the audience for questions. And if people have questions, if they could put them in the Q&A box. So we've got a great panel for the session with a real depth of expertise on NTDs and in particular experience of programming through the COVID-19 pandemic. So on the panel today, we have Yoasha Radvan, who's the NTD coordinator at Sightsavers, Dr. Abdurrahim Sise, who's the country NTD manager for Sightsavers in Guinea, Geordie Woods, who's the technical director on NTDs at Sightsavers, Pelagie Boko Collins, who's the senior NTD program manager at Sightsavers for Benin and Togo, and Dr. Nicholas Olabio, who works in the Federal Ministry of Health in Nigeria as the deputy director and program manager for the National Trachoma Elimination Programme. So perhaps at this point I can hand over to Yoasha and Sise to introduce the first paper, which is titled Resuming NTD Activities in the Context of COVID-19, an investigation into the advantages of risk assessment processes to mitigate the transmission of COVID-19 during NTD delivery. So Yoasha and Sise.
Thank you, Simon. Next slide, please. Thanks. So, good afternoon, everyone. Our article on resuming NTD activities in the COVID-19 context essentially explores the ways in which programs have adapted throughout the pandemic. And I'd like to just start off by saying a big thank you to all of the co-authors of this article from Sightsavers, along with the colleagues from Ministries of Health of Liberia, Nigeria, and Guinea, for their collaboration throughout this entire process. Thank you. Next slide, please. So to start off with some context then, as I'm sure many of you can remember, back in April 2020, NTD activities were paused following a WHO advisory. And this decision was evidently a concern for NTD programs, as these interruptions to delivery would delay the achievement of 2030 elimination targets. But in July 2020, the WHO guidance advised that activities could resume as long as mitigation measures were in place. And WHO also published a mass gathering COVID-19 risk assessment tool for generic events. Next slide, please. Thank you. So what was our response to this? So in response to this guidance and this mass gathering tool, the Ascend programme, alongside national ministries of health, adapted that tool for generic events into a tool that addressed the specific needs and considerations of NTD activities. And 3 tools were developed, one for MDA, one for surveys, and then one for surgeries as well. And the tool lists any risks and any mitigations that should be considered whilst preparing for an NTD activity, so either MDA, surveys, or surgeries. Next slide, please. So following a piloting stage for this tool, the Ascend programme then developed a 7-stage risk management process. And there were several stages to this process, but it included the monitoring of COVID-19 trends and the technical review and verification of COVID-19 standard operating procedures for each separate activity. So overall, the RAMA process was completed for 164 activities across 26 countries, as you can see there, between June 2020 and April 2022. Next slide, please. And you can see here the reach of the RAMA process. That's in many Ascend countries, but also beyond Ascend countries within that time. Next slide, please. And alongside the RAMA tool and the RAMA process, a guidance document was developed in English, French, and Portuguese, really to ensure that the guidance was clear and that activities could restart without further delay. Next slide, please. So our paper is really an evaluation of this risk management process. We've taken 4 semi-structured interviews, the content from within those interviews with colleagues from the Ministries of Health in Côte d'Ivoire, Guinea, Liberia and Nigeria, and we've grouped these into key themes. And we also used results from the application of ComCare, a mobile health application used by MDA supervisors to monitor compliance to COVID-19 mitigation measures by teachers and CDDs, to really try to gauge the effectiveness of the RAMA process for mitigating risk of COVID throughout these activities. And I'll now pass to Cisse, who's going to summarise the key takeaways from the paper and some of the challenges too. Next slide, please.
Good afternoon, everyone. So I'm going to talk about the key takeaways. And essentially, we have 3 takeaways emerged from the interviews and the monitoring results. The first theme is adaptability and innovation. The RAMA process has helped guide programs to conduct activities safely and given the opportunity to think innovatively and outside the box. Numbers of CDDs, methods of distributing medicine, community engagement, and awareness raising are just some examples of the ways in which the RAMA process has helped to adapt the program. The second theme is collaboration and government ownership. The RAMA process promoted enhanced collaboration with online meetings, cross-sectoral collaboration and communication, and the necessity for up-to-date information from multiple sectors. The third theme is preparedness. The RAMA process provided guidance for implementers, which was adaptable to the country context and suggested preventative measures. The results from the ComCare app show that across the states implementing MDA, 84 to 99% of CDDs use hand washing facilities and 90 to 100% complied with social distancing, and 89 to 99% showed correct use of PPE. Next slide, please. And despite these benefits, the RAMA process did bring challenges. A significant amount of time and resources were required to complete the process. At that time, when misinformation COVID-19 was circulating, mitigation measures could be difficult to apply in some cases. There was low COVID-19 testing capacity, which meant that sometimes monitoring of cases was difficult, and thus the information inputted into the RAMA tool would have been circulated inaccurate. And there were also some limitations to this second part. The digital supervision tool, ComCare, was not available everywhere, and therefore we weren't able to compare the results in Nigeria with results in other countries. We also suggest that a better analysis and comparison is needed of other COVID-19 risk management processes within other organizations. Thank you. I will now pass over to Jordi.
Thanks, Aisha and Cisse. And yes, perhaps I can pass over to Jordi to introduce the second paper.
Good afternoon, good morning, good evening, everybody. Thanks for being with us. I will keep this brief, but the second article is really just a reflection on the response that the Ascend program took when the world changed. The picture you see here is the new rules, so everything changed during the pandemic, and really sort of how the NTD platforms are placed to respond to pandemics and potentially future pandemics or other health crises. Next slide, please. So I think it's been well documented and in the past, but one of the value of the NTD platforms is there's just a lot of, they have a very unique position in terms of health programs. So in March, when it fully announced the directive to flex that funding into COVID response, one of the things that I saw from the slides earlier today was that 6.6 million were spent on social behavior change, which is unheard of for an NTD program. So it only takes a pandemic to have that kind of funding focused into social behavior change. But kind of going back to how NTDs are uniquely platformed, are placed is, the premise of a lot of the distribution of mass drug administration is this huge network of volunteers that are able to deliver all of these drugs and programs and different services to some of the most remote areas of countries. So really a wide reach, and also being able to reach the most marginalized populations, hence neglected. The other part of that is, these are very trusted programs. They've been happening for a very, very long time, so that we have access to a lot of information and a lot of networks within that. And one of the others, really sort of valuable contributions that the NTD platforms had kind of moving into the pandemic was that because of these networks and relationships at all levels, from sort of the national level all the way down to the community, is that the NTD members and community folks were existing members on all of these COVID-19 task forces that were eventually created. Next slide, please. So I guess one of the themes of the paper is really sort of what innovation and sort of multi-sectoral partnerships were able to be forged through the response of the NTD programs and again sort of just resilience. I think that one of several of the innovations that the NTD programs really offered is that we were really able to focus on accessibility, and all of the programs that I'll talk about in a minute in terms of the social behavior change programs, we really tried to fill that niche of making sure that accessibility and targeting persons with disabilities was a key piece. That was one of the big gaps across all of the countries in terms of what country responses to COVID were responding to. So that was one of the things that we were able to really leverage on and fill that gap. Again, the second point, filling those gaps. So one of the things that we were able to do because of the broad network was to do a really rapid mapping of what were the existing needs. And because there were so many, all of the health programs were responding immediately, there's a lot of noise happening. So we were trying to fill those gaps rather than to just add existing communication or messaging to the already very, very full platform of messages. And I think that last point is just that because of that network, the NTD programs were able to respond quickly to that. Next slide, please. And there's an example. So just sort of getting to kind of the meat and potatoes or grain of the program, we engaged, MNC Saatchi was one of our main partners here. And so we had this expert creative support in development of behavior change communication campaigns across all of the countries. So in total, it was 11 countries. 9 of those were sort of directly supported by our partner, MNC Saatchi. We trained health workers. We were able to provide lots of sanitary supplies as well as other types of COVID PPE type of supplies. And then the main bulk of that really was focused on filling those gaps in terms of messaging across the campaigns. Next slide. Just another example of some of the really great communication and just art that kind of came out of this whole thing. But if this number was mentioned before, I mean, that's a big number. 137 million people were reached in 49 languages. So that's a huge scope that this program was able to leverage on. 13,000 health workers were trained, and 23.8 million people were reached with direct sort of peer-to-peer community sensitization activities. So it was a very, very large scope of this program. Next slide, please. And just to wrap up, I think that, again, kind of stepping back to the 20,000 foot view in terms of how NTDs are placed to respond to future pandemics, they're really, the NTD program was really very agile and able to work with other programs. And I think that multi-sectoral piece became very, very important. So I think the NTD programs, who sometimes sort of work on their own, were really able to kind of combine efforts and address the pandemic by working with lots of other programs at the same time. Again, just making sure that this is a much more cross-cutting health systems focused on using the NTD's sort of expertise in the most rural and most marginalized populations, and some of the expertise around different folks with disabilities and different types of health issues. I think really brought and filled that that hole in the pandemic. And again, I think that just being able to address other health issues other than NTDs by using this network and within our expertise is a lot of the lessons that we learned from that. So that's sort of an overview of the paper and a brief summary of what we did. I'll pass it back over to Simon. Thank you.
Thanks, Geordie. So perhaps to start the discussion, perhaps I could ask Yoasha and Geordie, what recommendations have emerged from both papers that you think could help the sector prepare for future pandemics?
Yeah, so I can go first and then hand over to Geordie. So as well as the three main themes that we highlighted during our presentation, our paper actually concludes with several recommendations for maybe how we could deal better with future pandemics. So one of the recommendations is that the next step could be to take the RAMA tool out of the NTD sector and develop it into a tool that could be used to inform future pandemic responses to other health sectors that involve mass administration of consumables. So not just an MDA, but something like malaria bed nets, for example, during any future pandemics on the same scale or on a smaller scale or on a bigger scale than COVID-19. And we also recommend that the structure of the RAMA tool can be applied to other subject matter, so not just to NTDs. For example, a Leave No One Behind assessment tool for NTDs was drafted almost based on the structure of that RAMA tool. And this tool aims to provide instructions for service delivery for populations at higher risk of being excluded because of geography or disability or gender or other inequities. Another recommendation that has emerged is that we advocate for the timely and sustained delivery of and equal access to the COVID-19 vaccinations. So slow rollout of those creates an environment where COVID can replicate and produce variants of concern, which would no doubt impact negatively on NTD programs. We also recommend that national programs integrate these COVID-19 SOPs and RAMA mitigations into the standard approach to strengthen epidemic preparedness and response to future pandemics. And this will help to avoid delays in delivering treatments in the future during potential future pandemics. And we also advocate for sustained collaboration with the World Health Organization to share experiences with them from the application of the RAMA tool to inform any future risk assessments that there might be. But we also note that it's important to update this process to reflect the improving COVID-19 situation. And actually in April 2022, the streamlined RAMA guidance was shared. So those are just a few of the recommendations that have emerged from this paper. Geordie?
Thanks, Yoasha. I think from our paper that the main recommendations that came out of it are fourfold. The first would be really just integrating approaches that address multi-diseases as opposed to focus on single disease. I think that's been a theme within NTDs in general, but really kind of being able to sort of flex, using that term, to COVID-19 and many other diseases. The second part, I think, is really, again, I'd mentioned the huge investment in social behavior change and prevention, but just the importance of scaling up investment in prevention and preparedness strategies. Part of this having a tool to be able to respond, but also investing in the prevention elements of all of these programs. And then sort of related to the first one was, that these NTD programs have the potential and expertise available within them to address a broader breadth of health issues and not just NTDs. So how can we explore these NTD platforms to have other opportunities to springboard for other health issues? I think a good example of that, which is the fourth recommendation, is leveraging NTD platforms for distribution of vaccines, for example. So those are the sort of lessons from our paper, and I will pass over to any other questions.
Thanks, Geordie and Yoasha. So perhaps at this point I can bring Palaji in as someone managing a program in Benin and Togo. So what do you see as some of the challenges faced in actioning the recommendations from both papers?
Thanks, Simon. Well, one of the biggest challenge we had was the rollout of the NTD activities simultaneously with the vaccine rollout. in the context of mistrusts and misinformation. And what we did was we had to step up sensitization and raise awareness, and this has increased acceptability of the vaccine, of course, and acceptability of our treatment we were providing before the pandemic. But then the biggest challenge was that ensuring the availability of the vaccine and leaving no one behind in the current country, anyone who needed treatment or accept the vaccine, making sure they have access to it. That was very difficult to achieve. And one thing also I've learned is like adaptability is a great skill we all admire, but change is challenging. And we need to remember that each time there is a new context to adapt to. The NTD program finally accepted to adapt the SOPs, taking into account the mitigations, but it required perseverance and determination. Compared to your goal, your target is always difficult. The digitization has really helped us in this way to improve the service delivery as we include the mitigation action plan in the supervision checklist. And finally, I would like to add to that the importance of integrated approach in such contexts. All NTD donors required were engaged within the same country with the NTD program, but we needed to have integrated approach in such context to ensure we all protect in the same community in line with the recommendation. Those were our challenges. And you know, donors do not have always the same vision or approach. So sometimes it can be really challenging. Thank you.
Brilliant. Thanks, Pelagie. And perhaps turning to Nicholas as someone, you know, working in a Ministry of Health. So how has the Ministry of Health in Nigeria replicated any useful elements of the risk assessment process? And I think you're on mute, Nicholas.
Oh, sorry. I would say, apart from compliance with protocols for all activities like meetings, trainings, travels, and field activities, the security risk assessment is one thing we have found very useful given the way Nigeria is. And then security managers to provide security updates for us before we embark on any field exercise. In addition, the ministry has a COVID-19 guideline adapted and presented to guide operational conduct in all our meetings. Finally, I would like to also say that the NTD activities resumption before the relaxation of the COVID-19 restriction by government was in line with within the RAMA process. Thank you.
Great, thanks, Nicholas. And just turning to Cisse, from your experience in Guinea, how's the Ministry of Health in Guinea replicated any useful elements of the sort of social behaviour change COVID flex model?
Thank you so much for your question. I would like to start that's the mission from Sightsavers to strengthen capacity of the Ministry of Health by implementing the activities. So as our former president said, epidemics and pandemics have been opportunities. But when he said that time, people didn't understand because he just thought there it's an opportunity. And I can say it's true because COVID-19 has been the opportunities for countries to improve their health system. So in addition to what we've done with COVID-19 by epidemics, the guidelines were developed by Ministry of Health and the contingency plan for implementing activities during the health crisis. I would also like to add that the Ministry of Health now has the standard procedure for each program that's based on the RAMA process model. And finally, the NTD's program continues to hold community meetings from advocacy which have helped to reassure the population during the activity implementation. Thank you.
Thanks, Cisse. And perhaps coming back to Nicholas, could you speak about one thing that didn't work so well and that's something that you wouldn't repeat?
I would say adherence to mitigation measures was really difficult, particularly at community levels, where people did not believe so much about COVID-19 and where there was so much dependence on resources provided by NGOs. In this instance, only implementers supported by partners were those that mostly complied with SOPs, and even this, it was really difficult. Weather conditions that made wearing of masks over a long period of time really difficult.
Thanks, Nicholas. The sound was a little obscured there. So can you just say the last bit again?
Okay. Sorry, I'm just I'm joining from the airport. So I said adherence to mitigation measures, particularly at community level, where people did not believe so much about COVID-19 and where there was so much dependence on resources provided by the partners. And in situations like this, only implementers that mostly complied with the SOPs. And it was even more difficult at times because of the weather, the kind of weather conditions we had. And it made wearing time really difficult. Thank you.
Great, thanks, Nicholas. So I sort of opening up questions to the floor now, and I've had one question already from Joe Keating, and perhaps I can put it to Cisse and Nicholas. And Joe's question is, do you think that the positive changes that you saw with COVID will be maintained?
Okay, thank you, Joe, for your question. I think it's really maintaining because you know, COVID-19 brought some behaviors to people and to Ministry of Health, to actors during the field. And now it will be challenging. I recognize that some aspects will be challenging to maintain, like wearing face masks, but the online meeting, the supervision with online tool will be maintaining for sure for the future activities. I can see.
Nicholas, did you want to come in on that one as well? And Pelagie?
To be maintained, it's just like I said, it has brought lots of positives. Even when we carry out our activities, we still maintain those COVID-19 guidelines. Use of hand sanitizers, they are all still in the we are still maintaining all those COVID-19 very, very useful for us as a country.
Yes, and I would like to add quickly that indeed we had improved service delivery following this pandemic, because now everywhere beyond the PPE, you will see the SOPs are well followed, and that aids for the safety of both patients and both beneficiaries, whether it's the entity program implementing, whether it's the patient, and that it was something I think will remain, it definitely will remain in the systems. And for us, for example, with the trachoma elimination program, where you only conduct the surgery in the health center based on the eligibility, that is now embedded in the government system, and it's something very important we need to note. Thanks.
Thanks, Nicholas. Thanks, Pelagie and Cisse. So yes, and so another question we've had in from Finley White to Yoasha. Was there any collaboration between Sightsavers and WHO on the development of the RAMA tool? And if so, could you speak about it?
Yeah, thanks. In short, yes, there was collaboration between Sightsavers and WHO on the development of the RAMA tool. So as I said, they developed, WHO developed and published the mass gathering tool for generic events that was not specific for health events. And Sightsavers, along with National Ministries of Health and other partners, developed that into a tool that was relevant to NTDs. And we had ongoing discussions with the WHO COVID-19 mass gatherings technical expert group on the potential to take into consideration the specific learnings from the RAMA tool and adapt that original tool into a tool that could be used, like I said earlier, by other health sectors that involve those mass events. So turning the generic tool into a health specific tool was the plan there. And I think the plans for that were halted, I think, just owing to the fact that these mitigations seem to have been adopted by health programs. So perhaps there was not so much of a need for that risk assessment tool. But I think it's something that we could definitely pick up again in the future if needed. But there was certainly collaboration. And just as another example of that collaboration, so Dr. Alvis, who is team lead for knowledge management and strategic information for NTDs at WHO, spoke at an internal Sightsavers research session on that collaboration between Sightsavers and WHO, and also on WHO's response to COVID. So I think that nicely demonstrates the level of collaboration that existed there. So thank you.
Thanks, Yoasha. Yes, I've been asked to note a contribution from, and apologies if I got the name wrong or pronunciation wrong, Mamadou Koulibaly, who's suggested as a contribution, I think ensuring the availability of protective equipment and products must be a priority, not to be lost sight for WHO and for countries for better preparation against a future pandemic. Integrating the mitigation measures developed against COVID-19 into national response plans must be a priority. So then we've got a question from Delna Gandhi, who's actually formerly of DFID. Is there an assessment on the additional costs to programs from using the COVID protocols? And I don't know if Nicholas, you might want to address that from a sort of Ministry of Health point of view. Did that make sense, Nicholas? Do you want me to replay it? The question was, is there an assessment on the additional costs from using sort of new COVID protocols?
We've done a kind of just kind of an assessment, and from what we found is that it's really there's a lot of doing activities under the COVID-19 context. It's more expensive because you need to, for instance, if you are doing your training, you need to face your training. You understand? Instead of bringing people, a lot of people together, you separate, you face it, kind of face it. And also there's this COVID aspect that comes into the budget, like you need to procure PPEs and sanitizers, face masks. All those were not part of what we used to do. We used to do incorporate into the budget when COVID was we've incorporated, and it makes it really more expensive. So I think really it's kind of, yes, kind of more expensive, but it's worth it.
Great, thanks, Nicholas. So then had a question from Nasser Adamu to Geordie. How do you tackle social rumours in your programmes? In Niger, for example, the majority of the population believe that COVID-19 is a white people's disease or a disease not present in Niger.
That's a really good question. I think that you know, part of tackling rumors really has to do with making sure that the context in the rumors are that you're tackling, you know what you're talking about, because it's really context specific. And so you know, I think that one of the things that we really worked hard within this in this program was making sure that those messages were really well crafted based on the specific population we were targeting. You know, and that's one thing. Just I'll add that this has not gone away. I think that the COVID pandemic is continuing to affect NTD programs and other health programs in a negative way, in terms of lots of vaccination programs and even some of the mass drug campaigns, you know, believe that somehow that these deworming or vaccinations are a trick by the government to get them to be vaccinated. So, you know, these social rumors are, I think, part of combating that is really maintaining really clear understanding pulse on social listening and understanding how that's changing and responding to it quickly. So it's not an easy thing to do, but I think it's certainly possible.
Thanks, Geordie. Okay, I think there's time for just one more question before we come to a conclusion. And I got a question from Adrian Hopkins directed to Pelagie. So in South Sudan, we noticed using photographic evidence that guidelines were not being fully implemented. How do you monitor at real peripheral levels? Oh, yeah.
Okay, thanks, Simon. I will say it's country context-wise, the approach to adapt. There's no right answer or bulletproof answer here. You just depend. For example, in Benin, it's the government's approach. We align ourselves with the government approach. Their priority was definitely at the peripheral level. We call it sub-district level. Here, for example, there is a COVID supervisor, and we collaborate with this COVID supervisor at every level, department or district, up to the peripheral level. At the village level, of course, is like a group of villages are now a sub-district for us. And at that level, you have to work with the government chosen peripheral COVID supervisor to ensure they follow the guidelines. So, of course, it's more resources to manage at that point, but by involving them, we were able to monitor our activities properly, based on the SOPs. So, but in Togo, where we didn't have that approach, we have to rely on the reports of our own supervisors and the district level one. I hope that helps. Thanks.
Thanks, Pelagie. Yes, no, very, very good. So, okay, I think that brings us to time. So perhaps just to finish, could I say a big thanks to our panel, to Geordie, Yoasha, Cisse, Pelagie, and Nicholas for all their contributions. I certainly found that a fascinating discussion. Yeah, so thank you, everyone, and thanks for all the questions as well. Great, and perhaps I hand back over to Tamar.
A group of villages are now a sub-district for us. And at that level, you have to work with the government chosen peripheral COVID supervisor to ensure they follow the guidelines. So, of course, it's more resources to manage at that point, but by involving them, we were able to monitor our activities properly, based on the SOPs. So, but in Togo, where we didn't have that approach, we have to rely on the reports of our own supervisors and the district level one. I hope that helps. Thanks.
Thanks, Plaji. Yes, no, very, very good. So, okay, I think that brings us to time. So perhaps just to finish, could I say a big thanks to our panel, to Geordie, Yoasha, Cisse, Plaji, and Nicholas for all their contributions. I certainly found that a fascinating discussion. Yeah, so thank you, everyone, and thanks for all the questions as well. Great, and perhaps I hand back over to Tamar.
Lovely, thank you, Simon. And thank you to all the panelists. Just a reminder, we posted in the chat earlier the link to the supplement itself, so if you want to read more about that particular group of papers, you can. Okay, so we're moving on to our third panel, which is focused on leaving no one behind and equity in the Ascend programme. And for this one, the moderator is Wendy Harrison. So Wendy is Chief Exec of the SCI Foundation, which is one of the members of the Ascend Consortium. And she's also Honorary Professor at the Royal Veterinary College and former Vice President of RSTMH. Wendy, handing over to you.
It really is so lovely to be online with so many of friends and colleagues from the consortium, and obviously the key partner of the Ascend programme, which is our Ministry of Health colleagues. And I think this is a great opportunity over the next 40 minutes to really think about the equity of our most marginalised communities. And we're really hoping in this session to really discuss how we embed the Leave No One Behind approach to future programming, which is obviously going to be absolutely key to us reaching the NTD elimination goals and also universal health coverage. And also to open up the discussion on the importance of the feedback from the communities that we serve as a mechanism to improve our programme quality. If I could have the next slide, please, just to introduce you briefly to our panel. So we have Torres Vitalis from the SCI Foundation, who's a social scientist. We've got Abraham Abba, who's a programme officer at Sightsavers. Eduardo Nurendine, who's a program manager at Sightsavers, Danny Harvey, who's a program officer for learning at Sightsavers, and also Phil Downs, who's a technical director again at Sightsavers. So in respect of our time schedule, I'm going to hand over now to Danny, who is going to introduce the first of our articles around leaving no one behind. Thank you.
Yes, thanks. Good afternoon all. So the first article included in this panel today is an article focused on integrating a leave no one behind approach. And the title of this paper is How Can the Neglected Tropical Disease Community Be Inclusive and Equitable in Programme Delivery, Reaching Refugees and Internally Displaced Persons Through Integrating a Leave No One Behind Approach. And this article is authored by myself, Joy and Abraham from Sightsavers, Mark, who works for the Benue State Entity Programme in Nigeria, and Carlos, who works for the SCI Foundation. Next slide, please. Great, thank you. So we wanted to provide a brief background to Leave No One Behind and why it was critical to include within the Ascend programme activities itself. And we know that NTDs have a devastating impact on the most marginalised communities globally, where there are varying levels of vulnerability, exposure and access to services and treatment. So the concept of Leave No One Behind is as a proactive attempt and commitment to ensuring the equitable and inclusive delivery of services and treatments. And the Ascend West and Central Africa programme, where possible, built in a cross-cutting Leave No One Behind approach into all NTD activities with the recognition that certain marginalised groups, for instance, persons with disabilities, prisoners or nomadic groups, are often missed out from being included in programs. So for the article that we wrote for this supplement, we decided to focus and shine a light on our work in addressing the inclusion of refugees and internally displaced persons. And these populations are more at risk when residing in overcrowded settlements with inadequate sanitation There can be reservoirs of infection for NTDs due to migratory patterns, are often facing structural and logistical barriers and accessing or being registered for treatment. And we're seeing ever increasing numbers of displaced populations caused by insecurity. So firstly, today, Abraham is going to outline the experience of Nigeria in providing MDA treatment within refugee camps and internally displaced person camps in Benue State in Nigeria. Over to you, Abraham.
All right, thank you so much, Danny. With the Leaving No One Behind principle, also at the call of Sightsavers implementation, the Benue State Ministry of Health, which is one of Sightsavers partners in Nigeria, operationalized the Leave No One Behind principle in all her MDA activities. And they did this working with stakeholders. It's SEMA. So SEMA is an acronym which stands for the State Emergency Management Agency, which is the agency responsible for coordinating activities of internally displaced persons and refugees in the state. So working with them, the partner was able to map all IDP and refugee camps within the state prior to MDA. So this provided details of IDPs and refugees, which was used. So during program planning, all IDPs and refugee camps were prioritized for inclusion and treatment. All camp coordinators in the camps, IDP camps and the refugee camps were trained as supervisors, and IDPs themselves and some refugees were also selected and trained as drug distributors within the camp. So this led to the treatment of 29,579 IDPs and 2,000 captured. So these groups have become strategic stakeholders for every round of MDA planning and implementation in the states as the program focuses on elimination by 2030. So because of this, again, capacity of camp coordinators, as I stated earlier, and IDPs and refugees have been built on all NTDs. So with this strategy, the program is able to reach all eligible populations within the state during MDAs, thereby eliminating the risk of having reservoirs of NTDs. So due to continued crisis, that's the farmers and herders crisis within the state, discovered that more IDP camps have been cited in some cases, and in some places where the program would not be able to access. These were some of the challenges that we faced during the operationalization of this Leave No One Behind principle, because by assessment, these places were unsafe for staff to be able to access to provide support. This makes it difficult to provide the needed support and supervision during MDA. Also, these groups, I mean that the IDPs continue to be very mobile, seeking alternative camps with improved social and healthcare services, which makes them makes reaching them more or less challenging. Next slide, please. Focuses on the challenges that we encounter, and of course the recommendations that have been put forward, so that our other colleagues will be able to look at them and also pick. So what we did as the ministry will continue to sustain our partnership with all stakeholders working with refugees and IDP camps to facilitate identification of all of this camp. The program will also continue to assess and reassess IDP camps, considering the location of where they are sited, and where possible, we'll continue to use community structures to ensure that all IDPs and refugee camps are reached. So I will now hand over to Carlos, who will now share with us the experience in Niger. So Carlos, over to you.
Thank you, Abraham. Thank you everybody for joining us today. As Abraham said, I will talk about pilot study conducted in Niger. This was a project funded by the Learning and Innovation Fund from the ASCEND program. And we conducted this pilot in response to three major conditions that were being identified in Niger. The first one is that there is a growing number of refugees arriving to the country. There is ongoing violence in the whole Sahel region, as you know, and Niger already hosts over 200,000 refugees, mostly from Mali and Nigeria, but nowadays also refugees from Burkina Faso are arriving to the country. As Danny explained at the beginning of the presentation, these populations have very difficult living conditions. They already arrived to overcrowded settlements. Refugees have a large proportion of women, children, ill people, and elderly. One important thing that we need to remember is that they are refugees, not to a large extent because they were already living in remote, poor areas in the countries where they are originally from. So they were already in a vulnerable condition that became worse after the violence they endured. And when we conducted the study, we were also told that there was a limited intersectoral coordination with humanitarian actors with regards to refugees. There were teaming activities that happened over 9 years ago in the country, but after that, access to information in terms of what's the status of the refugees, the epidemiological circumstances, intervention activities happening, and the potential for coordination. There was limited exchange of information on the subject. So in this study, what we conducted was a comprehensive intersectoral examination of the different factors shaping the access to preventive chemotherapy among refugees in the country. Next slide, please, Danny. Oh, please, thank you. So this project was funded by the Innovation and Learning Fund because we trialed this system thinking approach to examine the problem of access to preventive chemotherapy among refugees in Niger. We talked to different stakeholders, both from the humanitarian sector as well as to the NTD sector. Because we were in COVID times, we talked initially to national level officials from these different stakeholders, but also a local team that visited a refugee camp in Oualam in Niger in order to talk to frontline workers to reflect upon the situation of the refugees and their access to treatment and preventive measures for NTDs in the respective location. Basically, we trialed this approach because this allowed us to identify, to map out not only the different factors that different informants were telling us about, but also to make connections between those different factors to see the positive and negative impacts between these different issues. And because of that, the different interactions that were happening in the whole system. How, for instance, some knock-on effects were being generated by issues starting somewhere remotely in the system. And because of the nature of the modeling work as well, it would be easier for us to understand which could be the potential areas where we can intervene and generate multiplying effects later on in order to maximize impact through our potential collaboration in the future on the subject. Next slide, please. Well, if you want more details about the study, you can read the paper, but basically, after the examination and the development of this model, we arrived to 5 specific recommendations. The first one concerned the importance of information about refugees. So basically, in the presentation, Abraham talked about camps, for example. But one thing that we need to be mindful of is that refugees not only live in camps, they also live in hosting communities and often in informal settlements. So, and they are constantly moving, as Abraham mentioned as well. So where are these refugees? How is the distribution in the regions across these different types of settlements? We lack information in order to have the basics to work on the subject in terms of providing preventive chemotherapy treatment. And at the same time, the Ministry of Health monitoring and evaluation tools often lack the capacity to provide integrated information on the subject. So even though we know that there might be refugees present in some communities where the Ministry of Health intervened, we don't really know to what extent maybe they have already been reached out by our MDA campaigns. Endemicity is another important factor concerning that we found that refugee settlements often lack the capacity to establish what the epidemiological situation of refugees. And so they don't know the situation, and I think there's potential for support from the Ministry of Health in order to find out what's needed in terms of treatment activities. We found that in certain camps, there were MDAs happening with humanitarian NGOs providing praziquantel, at least for schisto, as well as albendazole and ivermectin. and they were facing the same problems we have in an MDAs in terms of rumors, absenteeism because of work, lack of attendance to certain public services. And I think that we found that there's potential for knowledge exchange activities and benefiting from the expertise of the Ministry of Health, as well as from their own sensitization campaigns to promote participation in MDAs in refugee camps. And the final 2 points concern to the issue concerning planning. As I said, there are different types of settlements across different regions of the country. There are different NGOs working in different parts of the country with different types of interventions in different parts of the country. And because of that, in order to have a good understanding of what we can do on the matter, we need to ensure that there's participation of refugee representatives and humanitarian actors, both at the national and regional level planning, as well as the local level planning. Unless we develop a planning activity that cuts across all the different dimensions, it will be really difficult to address the needs of this vulnerable population in Niger. That's all from my side. Now we can move on to Danny. Thank you.
Yeah, thanks, Carlos. Thank you. So the second article included in this panel today is an article focused on Ascend's efforts to establish beneficiary feedback approaches. And the title of this paper is Responsive Neglected Tropical Disease Program Delivery, Listening and Responding to the Views and Perceptions of Beneficiaries. This article was authored by myself, Dauda Flake, all from Sightsavers, and Sarah Martindale and Hannah Hume from RSTMH. Next slide, please. Great. So the Ascend program really started our efforts in establishing beneficiary feedback mechanisms with stakeholders. And this is really a tool that enables programs to listen and respond and address to the needs and requirements of beneficiaries, can foster more efficient outcomes for programs, strengthen adaptive programming, and improve the quality of services as well. So in the Ascend West program, we piloted a study in the DRC and Nigeria to listen and respond to beneficiaries in the delivery of NTD services. And Dauda, who's been at the core of this work, will share more information now on this. So over to you, Dauda.
Okay. Thank you, Danny. And thanks again, everyone, for your participation in this event. The Ascend approach to strengthen beneficiary feedback loop followed a 4-stage process as outlined here. Now, the overall aim was to integrate beneficiary feedback loop within existing NTD process of the National Health System, rather than simply within the Ascend project. So in order to achieve this, first and foremost, an in-depth mapping was undertaken in DRC and Nigeria to understand the situation and context of beneficiary feedback mechanism in programming. Now, this mapping exercise led to the identification of feedback points, tools, and processes that are either being used as a beneficiary feedback channel or that have the potential of beneficiary feedback loop. Again, the mapping exercise also led to the classification of beneficiaries within the NTD program into 2 main categories as end beneficiaries and intermediary beneficiaries. The individuals receiving mass drug administration and surgeries were classified as end beneficiaries, while individuals providing MDAs and surgeries such as community drug distributors, case finders, supervisors, and nurses were classified as intermediary beneficiary because they are the recipient of training and capacity building. Now, the second stage was the design of beneficiary feedback strategy, including a suite of beneficiary feedback tool for receiving feedback from different categories of program participants. Now, these tools included training feedback form, interview questions with end beneficiaries through coverage evaluation survey, interview with CDDs, nurses, and other health sectors, as well as interviewing hydrocele surgery patients and the health staffs involved in hydrocele work. In addition to this, there was also the provision for the channels of unsolicited feedback, such as suggestion boxes. Now, this second stage was followed by the piloting of tools in 2 countries, which is Nigeria and DRC, as mentioned, to receive feedback from various categories of beneficiaries on their level of satisfaction, dissatisfaction, and suggestions for improvement. The final stage was the review of learning from the pilots to inform scale-up and future NTD programming. Next slide. Thank you. So this is an overview of the training feedback tool and the responses in Nigeria and DRC. The mechanism which reached the most respondents was the training feedback from the community dog distributors at local government area in Nigeria with over 2,000 responses in 6 states. Now, some key findings from this included about 97% of the CDDs who provided feedback said the training had equipped them to do their job effectively and at a high standard. And then when further asked about the level of satisfaction, the qualitative responses cited that CDDs feel mostly satisfied with the training content, practical demonstration, and hands-on experience in using the reporting tool. Now, in terms of a recommendation for improvements, there was a call to extend the length or the duration of the training. And again, CDD felt that training notification should be sent well in advance to enable them plan to attend the training appropriately. Again, hard copies of training materials should be made available to serve as reference points for the CDD. So overall, the participants were highly encouraged by their experience in providing feedback. Next slide. Thanks, Danny. So stemming from these experiences, the commentary brings together a list of recommendations to take forward. And we consider this a checklist for developing a beneficiary feedback mechanism. I won't read through all of this recommendation because of time, but I will highlight a few, and I can assure you, you will find all of it elaborated in the paper if you've not read them already. Now, first and foremost, in preparation and planning, it is important to consider the purpose of establishing feedback mechanism. So it is clear what you aim to achieve. Again, inclusion is key. Therefore, important to consider how to engage with the hard-to-reach group who could be at the risk of being left behind from the NTD services. Also, consider employing the use of mobile technology as much as feasible. From our ASCEND program experience, digitization of tools made it possible to quickly identify specific districts where specific elements of training, such as the venue or refreshment, were poor, and adequate steps were taken to address the feedback and then close the loop. The key point on integration and sustainability is the importance of not creating new process or moment of feedback, but looking at the existing processes and tools, such as the M&E tools, to identify, okay, how they can be strengthened in order to have more feedback within them. For example, in Sightsavers, we have embedded beneficiary feedback questions into standard coverage evaluation survey. So also working with the ministries of health to create ownership and foster the culture of feedback should be accorded due consideration. So thank you for listening. I will stop here and pass over to Wendy. Wendy, over to you.
Thank you so much, Darren, and thank you to all our presenters. And thank you to all our presenters, because I think these are really key insights into this really challenging issue around ensuring equity for those most marginalised populations, as we've heard. But we also realise that these are challenges that are being faced not only by the NTD community, but also by broader global health programmes. So first, I'd just be interested to hear how we think that these examples really speak to the broader recommendations from and guidance from WHO. So I wonder if I could perhaps ask Phil, who I see is online there, to just make some comments around that firstly.
Yeah, thanks, Wendy, and glad to be on this panel, and I'm really happy we're able to bring attention to this topic. I think the articles really do highlight how projects like the ASCEND project can make significant contributions towards promoting more comprehensive planning processes by health programs, a process that really encourages participation by the various stakeholders including the affected communities. Dowda mentioned sort of the intermediary beneficiaries in the design and development of services. And I think, responding to your question, it's a good reminder that the acronym Leave No One Behind, LNOB, is used in the 2030 Agenda for Sustainable Development as part of the SDGs. In addition, WHO, the Health Promotion and Social Determinants of Health Group, used the term in their technical handbooks for national health programs. And I think that's important to remember, because at the heart of LNOB approaches, along with the feedback loops, is really to ensure equitable service delivery and progress towards universal health coverage. And both of these issues are discussed in detail in the WHO NTD 2030 roadmap, and that was brought out and highlighted, even further during the Kigali Declaration, which really asked all NTD partners to help prioritize groups that are often underserved, including women and girls, persons with disabilities, minority groups, and other underrepresented groups that were highlighted in these articles. So again, I think the guidance from WHO, particularly in the NTD roadmap, really encourages us to embrace approaches that are more comprehensive and take actions to reduce, where we can, the inequities and vulnerabilities that place people at greater risks for diseases, including the 5 NTDs targeted by Ascend. So Ascend really did, I think, a great job in exemplifying how you use disaggregated data and the platforms that we have available to us to allow for this disaggregation within the countries to really help ensure progress for all population groups.
Brilliant, thank you. Yes, and I think we appreciate that the roadmap does kind of give us that mandate, and we've also got these great examples, from the Ascend program. But there are obviously constraints to be able to roll this out more broadly. So I wonder, Carlos, maybe you could just give us a few insights into some of those constraints.
Thank you, Wendy. Yes, I mean, if we start listing all the constraints, we are going to end up talking until 6 p.m. or later. So I'll just focus on 4, which I think are crucial, at least from my point of view. The first one, which Philip already mentioned briefly, is information. So the information systems, both from governments as well as from our own NTD community, are not always amenable to track down Leave No One Behind populations. As I mentioned in my presentations, for example, with refugees, our own monitoring evaluation systems don't allow us to understand, for instance, to what extent our MDAs have reached out to refugees or internally displaced populations. And official statistics are not going to provide us an answer either. So having access to quality up to the information is quite difficult, because the information systems we have are not already looking at this issue in detail. So there is a first problem there. A second one, of course, related to this one, is resources. In order to reach out to the hardest to reach, the most impoverished, the most socially excluded, we need to have additional support in terms of logistics, finances, as well as staff and time, of course. Both to provide treatment and services, as well as to monitor and gather information about them. To give an example from the center, I remember we had discussions about how much our samples will be increased if we wanted to have a statistically significant, a statistical estimate of the proportion of people with disabilities that have been treated by our programs. And what we found is that our sample will be increased so much that the cost of our routine M&E operations will be increased substantively. So when we're already in a situation when we're stretched in terms of resources, how much more do we need in order to invest in addressing the Leave No One Behind agenda is a question mark. And of course, the willingness to provide that support is still is to be tested on that matter. A third one, I think, is the institutional landscape. If one of the points with regard to leave no behind is that there are many different dimensions. You will talk about gender, poverty, exposure to violence, exposure to natural hazards, religious minorities, etc., etc. And each of those themes have their own network of NGOs, of public institutions, as well as UN agencies and other international agencies. And these are different networks. So the more we want to cut across all these different leave no behind dimensions, the more the challenge it is promoting an intersectoral effort that goes across almost the entire government, which implies, again, additional resources, time, logistics, etc. And finally, I think that's a point I would like to stress is that there is a reason why these populations are being left behind. It is that they are being left behind because they have no voice representation. They are excluded from the public debate. They are excluded from the policy debates and the public agenda. And this is challenging, for instance, when we try to highlight these efforts to include these populations into this policy debate, because the receptive environment is not always there, depending on what particular dimension we want to address. So, for example, one issue is refugees, but if we're talking about religious minorities or people with for other LGBT issues, for example, the reception will be different. And there is an important challenge there, which is at a societal level. And the point I try to make with that this last statement is that we need to be, and I think it's important for us to be aware that when we're doing this work on leave no behind, when we're trying to reach out to the social excluded population, the most marginalized one, it's not just about providing treatment to them. It's not about reaching our targets. I think that we need to be aware that our efforts to provide voice and representation to these communities, I think, can contribute somehow to help address the root causes of social discrimination and social exclusion. And I think that we need to envision our work in those two ways. Thank you.
Thank you, Carlos. That's enormously helpful. And as you've outlined, there are some very significant constraints. So I wonder whether, what practically then, can our program that we support actually do? So I wonder if, Danny, I could just ask you to perhaps give us some really practical approaches to take this forward.
Yeah, thanks for the question. So since the end of the ASCEND program, within Sightsavers, we reflected upon our Leave No One Behind strategy and felt it was really important to proactively target populations who are not routinely accessing NTD services. And it's really important to have a systematic approach ahead of treatment delivery rather than sort of ad hoc approaches, which is what we've seen before. So in Sightsavers, we established a draft Leave No One Behind risk assessment. And this is an Excel-based tool to facilitate a discussion between national programs and various stakeholders within national context to help identify who is at risk of being left behind, ask what barriers may be causing exclusion and discrimination, and how these barriers can be overcome as well. And so we've piloted this in Chad at a national level scale, and we saw various national organizations and associations involved. So the Association of Women and Nomads and of Youth come together to design an implementation plan ahead of the next MDA. And we've also piloted this in Sokoto, Nigeria, at a lower government area, also ahead of an MDA. And we're really seeing that providing a platform for NTD and marginalized group stakeholders to discuss and plan for greater inclusion and accessibility is having strong results. And so, for instance, in Chad, there was a conscious effort to address the exclusion of nomadic populations in programming through further identifying nomadic populations using available information, fostering greater inclusion from nomadic group leaders in the facilitation and delivery of MDA, including nomadic groups in the social mobilization process to ensure that messaging was contextualized. And we also had a GIS project as well in one district, which further identified over 1,000 inhabitants from nomadic populations who were routinely missed from programming. So this is really our approach going forward, to encourage our country officers to undertake the Leave No One Behind risk assessment a month or so before an MDA, and to prioritize specific actions within an implementation plan, and to adopt these into micro planning processes as well, and then filter it into the MDA itself.
Brilliant, thank you. Yeah, and that's really helpful for you to share that sort of more practical approach as we grapple with this. But I'd also be interested to hear how, in the last presentation around hearing from the marginalised communities themselves, and how we can really use that feedback again in a very practical way to adapt our programmes. And I wonder, Dowda, if you might be able to briefly just talk to us about that.
Okay, thank you, Wendy. Currently, the Leave No One Behind Risk Assessment tool, as highlighted by Danny, has been useful in bringing together a representative of marginalized group into MDA planning. This has further helped programs to identify approaches to improve MDA reach among marginalized communities. Now, beyond this, we now elicit feedback through standard independent coverage evaluation survey, as well as the post-hydroxyl surgery follow-up process. So we have also developed a focus group discussion tool, which can be used to sort of elicit feedback from specific marginalized population, as well as gather additional insight on the findings of, for instance, coverage evaluation survey. Now, in terms of how the feedback is operationalized within program, first and foremost, the feedback usually once received, analyzed, are often reviewed in conjunction with MOH. As a matter of fact, they lead the review process, and improvement actions are prioritized and used to inform planning. So I'll give two examples. First, in Cameroon, now there was complaint of lack of information about MDA campaign in 1 out of 7 regions where beneficiary feedback was collected through CES. Now, in response to this feedback, social mobilization approach have been expanded to include bulk SMS, use of megaphone and carrier van during pre-MDA sensitization, as well as working with school authority to send out letters inviting parents to school to witness deworming treatment. The second example is on the hydrocele program in Nigeria. So there was also a complaint about lack of mosquito net in hospital wards during hydrocele surgeries, and the program have now included, in response to that, included the rollback malaria program in the planning of hydrocele outreaches, so that insecticide nets can be made available to hospitals and patients during a hydrocele outreach. So the collaboration with the rollback malaria, in itself, it's another, a branch of cross-sector collaboration, if you like. So these are some specific examples of how we have continued to operationalize community feedback within programming. And I hope that answers the question.
It absolutely does, thank you. And it also leads me very nicely onto the questions from the floor, again around this kind of idea of that sort of intersectoral coordination. And we have a question from Gloria Boulis, actually for Carlos, who says, in your presentation, you've highlighted that there's limited intersectoral collaboration. So what efforts have been made to bridge that? Is there considerations in bringing together these relevant sectors to address and clearly spell out their roles? You can also consider developing co-created coordination frameworks. So Carlos, if I could ask you to briefly just comment on that, and obviously any other members of the panel, please, again, do come off mute if you'd like to make a comment. Carlos.
Yes, in terms of the actual intersectoral coordination, what we're doing at the present is to review our planning activities in order to ensure that there's further participation from the relevant stakeholders. That's still an ongoing process because when we think about the situation in Niger and refugees, is that neither the government nor the UNHCR have direct mandate to put them both together down say it in one place and decide what to do. So it's something that requires dialogue, and there are no short-term answers. But yes, ideally, what we will ambition is to develop a coordination framework for the future so that these things can improve over time.
Brilliant. Thank you. Yeah, and so I'm very sorry, but actually that means that we've come to the end of our panel discussion here. So if it just leaves me to thank enormously all the panel members and also for all the colleagues that contributed to these excellent articles, and obviously our Ministry of Health colleagues as well, because without them none of this would have taken place. And I'd like to just pass then back to Tamar. So thank you very much.
Thank you, Wendy. Thanks to all the panel members for that last session. So we've now got 10 minutes break, our second break. We'll be back in exactly 10 minutes time to start the last of the 4 panels, and then we'll have the final wrap-up panel. So see you shortly. Thanks. Hi everyone, welcome back from the break. So we have the 4th panel of our 4, and then some closing time. This one, the 4th one, is focused on strengthening health systems and leveraging resources. For this one, we're handing back to Dr. Eleanor Schmidt to moderate for us. And as always, the bios will be in the chat. Dr. Schmidt is Director of Evidence Research and Innovations at Sightsavers. So passing over to you, Eleanor.
To everyone. So this panel, panel number 4 for today, this panel will focus on system strengthening and leveraging resources for NTDs. We've heard already from the first presentations how important system strengthening is for the ASCEND program, and it effectively touched many health system blocks through its interventions. So we have a panel of experts with us today. So if I could have the next slide to introduce them. So we have with us today Diane Northway, who is the lead health system and financing, the team leader at Mott MacDonald. And Mott MacDonald was one of the consortium partners in the ASCEND program. We also have with us Dr. Joe Keating, who is the lead technical advisor on health system strengthening at FCDO. We have Anita Gwom, who is a senior program manager in Sightsavers NTD program in Nigeria. We have Phil Downs, who you met at the previous session, who is the NTD technical director at Sightsavers. And we have Alex Pavliuk, who is the senior technical director for health systems at Sightsavers. So as the structure of the session is the same as the previous session, so we will start with 2 presentations. So that will be the basis for our discussion on health systems. So the first paper will be on leveraging resources and the impact of neglected tropical diseases. And the second paper will be on the contribution of the ASCEND program to system strengthening and specific examples. And then we'll follow with the discussion. And then please, if you have any questions, please place them in the Q&A box. And as before, if you can, please say who you're directing your question to. Over to you, Phil, to present the first paper.
Great, thanks, Elena. And I'm pleased to summarize the opinion piece that Ian Jones, who's economic and financing researcher at Sightsavers, and I co-authored, leveraging resources and impact of NTD elimination programs, getting more, much more than what you pay for. Next slide. So, oops, a little slide before that. There we go. So while we do not quote the Greek mathematician Archimedes in the article, he is credited for saying, "Give me a place to stand, and with a lever I will move the world." And by move the world, Archimedes could have easily meant eliminate NTDs. And I think he could have made such a bold claim because he understood that if you identify the leverage point of a system structure, which is the fulcrum, and apply a solution element to it, a lever or a leva or lever, depending on which part of the world you're from, you can then enact greater change than the amount of effort placed on the lever. And the key is identifying where the lever should rest on the leverage point. And depending on where it is placed, it will affect how much energy, the force needed to affect the desired change. And it is considered a low leverage point if a small amount of force on the lever causes only a small change in system behavior output. It's a high leverage point if a small amount of force on the lever causes a large change in systems behavior. And in this diagram, the system is showing a high leverage point. And in the article that Ian and I wrote, we essentially make the argument that the ascend argument, which is a type of lever, was applied to national health systems in a way that resulted in a high leverage point. Next slide. So in looking at these three main components, solution, system, and problems, we should remember that the creation of national NTD programs was done in part because the limited resources endemic countries were providing through their primary health system in terms of infrastructure, health facilities, time and effort by the health workers, the community networks, and skills and training, was still insufficient by itself to eliminate the causes of diseases that were placing a burden on communities and the health system itself. Endemic populations continued to be undertreated and individual cases unmanaged. And as we know, the advent of drug donation programs really made it possible for countries to obtain safe and effective treatments for the 5 targeted NTDs. And this is in large part thanks to GSK, MSD, ISI, Merck Serono, Pfizer, J&J, who created and helped support these donation programs. And amongst the ASCEND supported countries, we estimated that there was 653 million pounds worth of existing resources within the collective health systems. This is actually a conservative estimate, and the true figure is likely to be considerably higher, but our estimate included 607.9 million pounds of drugs donated by pharma to government, as well as available time and effort by the CDDs, the case finders, and supervisors. And while considerable, it's still important to remember that these resources by themselves were insufficient to ensure that all eligible populations in every endemic community were being reached with quality services. It still needed a solution element, a lever. And so the ASCEND consortium, again mentioned, it was Sightsavers, SCIF, Liverpool School of Tropical Medicine, Mott MacDonald, worked with FCDO and the national and global partners in designing this solution element. And it consisted of various disease mapping, retraining of different cadres in the health system, enhancing supervision and monitoring systems, developing quality assurance processes. There's a whole list of various activities that were being supported through ASCEND. And then through a consultative process, which is included advice and assistance from technical experts and researchers, both within the consortium and outside of it, including WHO, we position those solutions so it could be effectively use that leverage point offered by each country's health system to then move the barriers that were preventing the eligible populations from being treated for infections and morbidity associated with NTD infections being managed appropriately. So without this consultative process, the Ascend project might have fallen short in getting underneath the actual problem. Next slide, please. And so Ian and I really wanted to highlight the importance of these components, because the success of the Ascend project was really dependent on each of these components working together. The 53.4 million pounds provided by FCDO through the Ascend West project by itself would not have been able to achieve the desired targeted change. It was, however, that force that was applied to the project, the lever, that then was able to leverage the $653 million pounds in resources within the countries themselves. And these components coming together is why we can say Ascend leveraged much more than what was put in, and allowed countries and ultimately allowed the local health system to improve service coverage of NTD affected populations. Next slide. So in Africa, 282 million treatments were supported under the Ascend West project. And if we broke this down by disease, that meant 35% of all treatments for onchocerciasis, river blindness, in Africa were supported through Ascend West, and 30% of all treatments for LF. In total, 117 million people were reached for at least one of the 5 preventative chemotherapy NTDs. The leveraging of in-country resources also meant that greater cost efficiencies were realized. It cost 15 pence per person reached. That meant for every pound of UK aid, 11.4 pounds worth of medicines were leveraged. And this value for money is really what makes disease elimination possible. But then on top of that, the Ascend project was also to do more. So other presenters have shared how the Ascend project assisted with COVID-19 prevention, attracted additional donor resources, strengthened the resilience of primary health systems by either transitioning capacities and technologies for NTDs into longer-term disease surveillance, and even case management strategies. So this too is what we mean by leveraging much more than what you pay for. Next slide. Thank you. So really the key takeaways from the article, which you can read in greater depth, one, partnerships are key to eliminating NTDs, but for partnerships to work, we need to recognize and give credit to the skills and resources that each partner brings to the table, and the different components that make leverage even work. And that includes the role of the donors, the government, the communities, the NGOs, and researchers. Second, elimination of NTDs, both in terms of the process and outputs, remains one of the best buys in public health. And then third, Archimedes was right. We can move the world with a lever, and in this case, eliminate diseases. But a certain level of effort, that force, is still needed to make the lever work. And in some of the Ascend supported countries, the levers need to be reconstructed, redesigned. But in other cases, the levers are still quite strong. And in all the countries, the health systems are still there and acting as a fulcrum for that lever to bring about major health impacts. Unfortunately, is now in many cases only the donor force that is missing. So again, I hope you all have a chance to read the article for more information. And I'll turn it back to you, Elena.
Thank you very much, Phil. That's really great and impressive. And I think using the laws of economics to prove the laws of physics, that's pretty innovative as well. So, but it's really good to have, because we've heard so many times that NTD interventions are very cost effective. It's actually, there are not that many examples of cost benefit analysis that in monetary terms express both your inputs and your benefits. And even with conservative estimates, we see that there's a significant level of benefits with leveraging additional resources that we have from the NTD investments. And now we will I will pass to Diane, who will talk about the second paper that you can find in the supplement, and that focuses specifically on system strengthening and how the ASCEND program contributed to health system strengthening for sustainable country-driven NTD programming. Over to you, Diane.
Thank you very much. A lot of this is a commentary paper which was presented, and it really does look at how we wanted to really take a country-led approach to sustainable health system strengthening. Laura set out many of the challenges for health system strengthening in her opening session this morning, or early this afternoon, which really looks at you know, how health system strengthening in an NTD program can contribute to health system strengthening overall, but recognizing the limitations that a health system strengthening in NTD program is not going to do the whole job. The other key points that she made, which is the fact that it's a long-term process, but you know, it's something that we actually took FCDO initial pondering on the subject and applied their thinking to our approach. If you just go to the next slide, please. Okay, I just want to hear, I mean, you can see how health system strengthening can be applied throughout the entire process, from the various activities, prevention, detection, treatment, surveillance, across different diseases, and ultimately leading onto health system development, universal health coverage. Now, in this context, what we're talking about with health system strengthening, it's the strategies and activities which are designed to sustainably improve country health system performance. And there is evidence that does show that impact of health system strengthening interventions does lead to improvements in service utilization, financial protection, quality service provision. So you know, all of the aims of universal health coverage. Okay, next slide, please. Now, our chief, where to start? That was our initial thinking. And we had to recognize that we have 12 countries, and they were all at various stages of whether it's disease status, whether it's maturity of their health system, maturity of their NTD program. And there was not going to be one solution that fitted all. So what we wanted to do to start with was to go down to country level and to try to identify what the priorities, where the actual issues were in terms of, you know, where they are now, what's the situation, what would it take to lean towards sustainability, and what are the priorities for the country. And the way we did that, we did initial country assessment, which were, first of all, we used a bespoke tool, which is the NTD sustainability tool, which was developed by Dahlberg for CIF. And it really does look at the sustainability dimensions of the WHO health system building blocks. It doesn't map exactly, but our commentary paper does show how you can map from one to the other. And basically, it's a quantitative scoring system, and really identified, you know, where some of the dimensions were more mature than others, and which ones needed the highest priority. We also wanted to supplement that for each country by adding our own tools, and we added on a public expenditure analysis, which was a tool we developed, which first of all looks at government income and expenditure, looks at the amount, the proportion which is going to health, and then digs down into health. How much is health spending on NTDs through its domestic resources, and how much is coming externally? And we also did a political economy assessment in each country to show how the main decisions are made within the health sector and the wider government sector on levels of funding, plans, etc. So the three tools together each contributed to a country assessment document. Those assessments were then discussed at country level with the NTD programs and Ministry of Health and other agencies such as health, water and sanitation, education, etc. And also we held regional workshops, which brought together groups of 4 countries to really discuss common issues and also areas of difference. And that enabled us to bring in wider partners as well. And we also included the teams that are working on the USAID Act to End program, which were many countries in common with the Ascend program. But also we invited representatives from ministries of finance and ministries of planning to really try to highlight the importance of NTDs being mainstreamed into the government plans. Also, I will say that, you know, in addition to the assessments for each country, there's a recognition that each country tailored solutions were required. So, you know, some countries were quite mature in terms of NTD diseases and were, either reached elimination or moving towards elimination, while others were far from it and were running programs which did not have full geographic spread, etc. So the solutions priorities are going to be very, very different for each country. From the regional workshops, each country was able to develop their own prioritized plan of where they considered their main HSS interventions would be, bearing in mind time limitations for the program, and where, you know, a sequence of steps along the way. We also coordinated with other programs that were working in the same areas. Common feature was particularly with the USAID Act to End program, which was running a very, very similar program at the same time with different timescales. They had a slightly longer horizon than we did. So we looked to see, you know, which of the agencies would be more suited to assisting with certain interventions. We wanted to, of course, avoid duplication, and we wanted to make sure that between us, we could give the best solution for that particular country. Thank you. Next slide. A combination of the reports and the workshops and the detailed discussion with the country governments really, in addition to developing detailed country plans, that also showed that there were common themes that were applicable across all countries. In particular, lack of domestic resources, domestic finance resources, shortage of human resources for neglected tropical diseases. So there were in addition to individual country issues, there were also common issues. The programme also coincided to countries starting to develop their NTD master plans. So what we did was we looked to see how we could support the countries best in that process. And again, like with their own health systems, they were at different stages of development. So in some cases, the country had already developed its draft master plan. So our role there was to facilitate some review workshops, contribute to the completion and finalization of documents. In other countries, such as Guinea-Bissau, they did not have any draft, so we supplied Portuguese-speaking public health specialists to help them work with the country to really develop their master plan. So different levels of support were given depending on the need. In the case of the human resources, we did a mapping exercise for every country, which looked at how many community health workers were in the system at the community drug distributors. What were the similarities and differences between different groups of staff, contractual, financial incentives, etc., and really try to highlight how future interventions could help integrating those groups of staff and eventually mainstreaming into the health system workforce. Sorry, next slide. In addition to those, I mean, these are just a couple of examples of how we actually supported individual countries with specific interventions. One example I've given here is information system strengthening in Nigeria. This was one of the systems particularly supported by Alex Pavlov, and really, digitized a lot of the data, which was then really assisting with strengthening the health system through, data accuracy, etc. And in the case of the Ghana health system, their particular master plan has far more developed than the others. This was really towards the end of the programme and our contribution. They had a costed master plan. So we supported them in the development of an NTD investment plan, which really was focused towards it's a companion document to their master plan. So looked at the costs and benefits of master plan implementation. Thank you. Next slide. Key takeaways. I mean, really, the strong dialogues with the Ministry of Health. It was really their key focus was identifying their priorities and what they felt was achievable and desirable, and sequencing. So very, very important. The other takeaway I would say was the inclusion of the wider government agencies. So bringing in Ministry of Finance representation, so they understand the issues that the programs and the health ministry are facing when it comes to raising additional domestic resources. Bringing in planning to make sure NTDs are represented not only in health sector plans, but in country development plans. And also the regular dialogue with the other NTD stakeholders and other agencies, particularly, say, USAID, where there was very, very much a shared interest in the work. We were, included them in all of our workshops, but also regularly we're exchanging plans, etc., to make sure that we could promote a harmonized approach to reaching the NTD targets. Thank you. Next slide. That's it. So
thank you very much. Thank you, Diane. It's really very interesting to hear very specific examples. So when programs start on the ground, so where do they start with health system strengthening? What are the specific initiatives that they can make to make systems to to ensure that the systems benefit not only in terms of NTD elimination, but also other health interventions. So we'll move to our discussion, and it was interesting to hear in both presentations that partnerships and working with the broad range of partners, both within the health sector and outside the health sector, is very important for NTD programs. And yet we very often hear that NTD programs are vertical and they work in silo. So maybe we could start our discussion, but specifically saying, so how could we summarize this experience of the ASCEND program, how NTD programs actually contribute to health system strengthening, and more importantly, how we can communicate that message both to donors and national decision makers. Phil, I'll start with you.
Yeah, difficult question. So to me, when we say siloed programs or vertical programs, it really doesn't imply that decision makers are not seeing the opportunities to leverage resources with other disease programs or other sectors, or maybe that integration and multi-sectoral approaches aren't even feasible. There are, of course, certain factors that influence opportunities to integrate or mainstream, and I promised I wasn't going to use a lot of jargon, but here I am using a lot of jargon. But whether integration is even possible really often depends on the co-endemicity of diseases in an area, which phase in the elimination journey a country program is in, whether it's in the very beginning, in the middle, or end. Even the complexity of particular interventions. I think as was presented, some of these survey methodologies are quite detailed and quite complex. And even in a multi-sectoral approach, it can vary in terms of complexity, and formality. So you could have just basic sharing of information between programs, which is still, important, and you can build upon that to more complex agreements on shared responsibilities. Obviously, the 5 PCNTDs that were targeted by the ASCEND project showed that in very significant ways that integrated drug delivery platforms can help bring down these siloed vertical ways of thinking. And we've demonstrated within the NTD community that there are very good examples of cross-sector collaboration between NTDs and the WASH sector. There's certainly a greater appreciation for viewing elimination through a more holistic lens, like One Health, and I think we should give credit to SCIF and WHO, of who I think have really helped promote that. There's obviously ways, more things that we can do to foster less siloed approaches, and really to ensure that the health systems are less stronger after disease is eliminated. But I think maybe the NTD programs and the ASCEND program has been the most successful, I think, in demonstrating ability to strengthen health systems when they've helped to identify inequities in service delivery, both for the infection through surveys, but also disease management. And I know that doesn't sound like a positive thing, but essentially it means that because of the routine monitoring, evaluation, and reporting that is being supported by the NTD programs, it is actually helping the health system identify not only where there's poor coverage for NTDs, but poor coverage of service delivery for health services in general. So if the NTD platforms can help raise awareness on the issues that undermine service delivery and then offer solutions, we effectively are improving universal health coverage and strengthening the routine health systems ability to plan and address inequity, and that ultimately helps sustain the elimination milestones. And just, if we have a little more time, just because I think it came up in the L&OB discussion, I think it's also important to identify what motivates various partners, and what encourage us to look at less disease siloed approaches. Ideally, we are collectively using our investments to lower barriers for collaboration and promote shared incentives. It really depends on how the partners is approaching their particular disease concern, or maybe it's not a disease at all, but it may just need to start with some basic sharing of information, and then we can build from there, as I said. But investments in NTD integration with national systems, I feel, should really be viewed in terms of this broader return on investment that benefits both NTDs as well as the other as well as other health issues.
Agree. I'll come. I see David raised his hand, and I'll come to the audience in a few minutes. But we've heard from Diane's presentation that NTD, that Ascent contributed to the NTD master plans, and also it's very important that they're linked to other development plans and strategies of the countries. Alex, maybe I could ask you about the alignment between donor and implementing partner initiatives and NTD master plans, as well as other health strategies and other development strategies in countries.
Yeah, great. Thanks for the question. So, as Diane mentioned, and actually quite a few folks today throughout this session has mentioned, there's been a lot of investment in developing these master plans, both by the Ministry of Health, by partners, by donors. So we really do want to see, these well thought through plans contributing to program development, program implementation. And we really need to think about the new NTD master plan really had 3 fundamental shifts that I think really speaks to how these could be integrated into planning for programs. And that focuses on the increase in accountability by switching to focus on impact indicators rather than process indicators, which may have been the way things were done primarily in the past. Another element speaks to what Phil just talked about the move away from disease vertical siloed solutions to more mainstream solutions, integration into national health systems, integration into national health management systems. And then finally, that shift towards domestic financing and really program ownership. So a shift away from externally driven, partner driven, donor driven towards country ownership, country finance programs. So I've spoken to a number of program partners and donors about, what is the impact that these country master plans have had on the development of work plans. And, I really want to say I see a shift away from the disease vertical program where MDAs or morbidity management that's done through outreach is really moved towards integration into national health management systems. And that's important because, that shift is happening both at country level, but also at global level through donors and partners who are really helping to develop NTD modules for HMIS, for National Health Management Information Systems. And that also contributes to another point of, as we see this shift away from the externally driven programs to more country ownership programs, I think that mainstreaming really helps to highlight the burden that NTDs place on populations. When these data exist outside of national health information systems, it's very difficult to be able to evidence those calls for increased domestic financing. So by moving towards a mainstreamed approach, you really provide that evidence. And then finally, I just want to mention the fact that programs are starting to be reflective of this new shift. If we look at the ARISE 2 program, for example, really focused on working with countries to identify their priorities and then identifying a partner that can provide technical input to be able to achieve those activities. So I think all of that together really shows that the master plans are playing a role.
Thank you, Alex. Thank you. And thinking about some specific examples, maybe we can talk specifically about Nigeria. Anita, maybe could you talk us through specific examples of a system change that was introduced in Nigeria, sort of with that system strengthening in mind?
Thank you very much, Elena. So I'll carry on from what Alex has discussed earlier on. I'll take one aspect of integrating of the data integration into the National Health Information System so as to raise the profile of the NTD program. I'll pick on a particular state. So we have been talking about silo programs, and we know before now the NTD programs data reporting has really been siloed. So what happened was that I will give an example of Kwara. In Kwara State, we implemented an electronic-based reporting of NTD data using the DHIS2 platform. And in this was also to strengthen the building block of the health information system of the state. And so we are seeing two aspects here: integration, data integration, and also strengthening the information system of the state. Now, the NTD program was supported to implement this electronic reporting of the NTD treatment data and the NTD treatment data in the state through real-time mass drug administration reporting tool. And the system was used to monitor and report on the NTD data and also drug stock indicators at the community level now. So using the DHIS tool, the community summary forms were collated and entered using the government, local government, at the local government level now. And in addition to this, the process involved the M&E unit of the MOH now. So normally before now, the NTD does not work with the M&E unit. But because of this system now, the M&E unit were actually the ones that did the entry for the NTD treatment data into the platform. So we observed that, the MOH observed that in the process, the tool had a lot of data issues that it has reduced, such as delays in data collection, errors, and other data inconsistencies that we normally experience before we went live on real-time reporting. So currently, the national is seeing how we can scale up this aspect of electronic reporting for NTD data. And this was incorporated in the new master plan, the Nigerian Country Office. The Nigerian government is developing now for 2023 to 2027. And we're also planning to scale up to other states. Currently, we are implementing this in 12 states across the country. And hopefully this will be scaled up across all. So we can see two aspects now: integration of the NTD program and also strengthening the health system for data reporting. Thank you.
Thank you very much, Anita. It's very, very interesting discussion, but we're really running out of time, unfortunately. Maybe briefly, Joe, sort of thinking about future NTD programs, sort of based on what we currently know, what are the opportunities for NTD programs and how can they be designed with based on those system strengthening approaches?
Great, thanks. And thanks for inviting us to this. There's so much learning, and a lot of what I was going to say has already been said. It does strike me, though, I'm not an NTD expert, and I hear the same discussion happening in multiple other forums. The same challenges, the same tools going ahead, the same. So you've already talked about it a lot. But you really, I think we need to, I hope in 10 years' time, we're not talking about NTD programs. I hope we're talking about essential packages of care. I hope we're talking about people-centered care. I hope we're talking about different levels, primary healthcare. I hope we're not talking about individual components within those. So I do think that we need to sort of challenge ourselves, that the narrative needs to change. I think we need to, you know, health systems is as much a political debate as it is a technical one. And we're all technocrats, I think, on this call. And we have to think a bit more in terms of what the political arguments are for this. And it's not just about, Phil, you know, Ian and I worked a lot. I don't think it's just about how much it can leverage. I think it is now a case of how can domestically we get these packages of care that are protected by other bits of the package to be domestically financed. And if you don't get in there now, I think we're going to lose. I think it will always remain siloed. And that requires...
Diane, we've heard about WHO-led guidance on sustainability. How did Ascent program contribute to those guidance?
Hi. I mean, the timing was slightly off for us on the WHO guidance. However, we were fully aware of the development. We were contributing to the development through reviewing documents, reviewing drafts, joining workshops, etc. So although the final document wasn't ready by the time we finished Ascend, we had contributed to its development. And the approach that that guidance takes is actually very, very much the approach that we took in Ascend by, first of all, doing an assessment of the systems that are currently in place and what steps are needed towards sustainability for each of the dimensions for the WHO building blocks. So the sustainability tool that we initially used in our assessment really helped the countries drill down to where they are and where they needed to be heading towards. I won't say necessarily achieving by the end of the program, because it's very, very long scale aims, some of those, but certainly moving towards sustainability while they were preparing their prioritized action plans. The work that we did would also be fed into the master plans and also be transferable to the sustainability documents.
Thank you very much. It's such a broad topic, health system strengthening. We could have, 3 days workshop about it, and probably there will still be a lot to cover. So we unfortunately have run out of time. We had a comment from David Molyneux, which I think we still have another panel discussion, and that will be for closing remarks. And we also had a very good question about M&E and monitoring NTD programs from the health system perspective rather than sort of output result perspective. And again, I think it goes broader than the health system. So maybe this is a discussion question that we can take in the closing panel. And I would like just to thank all the panelists for their presentation and very interesting discussion and all the points raised. And I pass it over to Tama.
Lovely. Thank you. Thanks, Elena. And thank you to all the panelists on that last group. So we're here at the final session now, and we've got just under half an hour to go. And what a hard job we have with our panelists. What we want to do really is think about everything we've heard about the Ascend programme from the supplement, think about what's been achieved and all the successes, and then move to the future and think about how we keep momentum going towards those important goals of NTDs. And so I'm going to ask our panelists, I'll introduce them in a second, I'm going to ask them to answer the question of what they feel is needed for us to ensure future impact and success, given where we've got to. We've got 4 panelists for this final session. So introducing back Laura Westcott, Deputy Head of the Health Institutions and Health Security Department at UK FCDO. Also welcoming Perpetua Amodu-Agbi, who is Deputy Director, Head of Monitoring and Evaluation at the Neglected Tropical Diseases Division of the Department of Public Health, at the Federal Ministry of Health in Nigeria. Thirdly will be Dr. Joy Shoalbu, who is Director of Programme Operations at Sightsavers Nigeria. And lastly, Professor Sir David Molyneux, who is Emeritus Professor at the Liverpool School of Tropical Medicine and at the University of Liverpool. And I'm sure everyone here knows David. So if I can pass to you, Laura, first, for your thoughts on what you feel is needed to ensure future impact and success.
And as you kind of touched on, I'll touch on a few of the things that I've taken away from the discussion today, as well as some thoughts on next steps. So, I mean, I think there were lots of lessons today around how NTDs and NTD programs can integrate with wider health system strengthening and UHC efforts. So in particular, I would emphasise, the learning so far around health system strengthening and assessments, and those being context specific and worked on in collaboration with ministries of health. Also the lessons around leave no one behind, and hard to reach populations, and community health worker and drug distributor lessons as well, and thinking about how those can be widened out to the wider health system. There's some interesting lessons there around resilience, for example, and again, the contribution to the COVID-19 response that NTD programs were able to make. Also a lot of expertise as part of that, a lot of expertise around communications for public health is something that came out really strongly from the programme as well. And so in terms of next steps, I think an important next step is around bringing those things to the table and thinking about how broader health system strengthening efforts can benefit from those, and that's not just about benefiting those broader efforts, but that's the way in for NTDs to benefit, I believe. And as Joe touched on, this is really about aligning behind UHC efforts and making sure that NTDs are reflected in that in terms of essential packages and so on. So on next steps, I don't think any of this is easy. I'm not claiming that it is, but I think that an important next step is to think really practically about how do NTDs get into that effectively. What discussions are going on, what groups are there, and how can NTDs get in there and bring what that programming can offer to the table and benefit from in return. Thanks,
Laura. Perpetua, your thoughts on next steps?
Okay. Thank you so much for inviting me to be part of this team. And my thoughts on next steps. A lot of things have been said on the session, and I want to apologize for joining in late. A lot of things have been touched on especially the health system strengthening, which has to do with partnership. No one style can fit into eliminating NTDs. We need to look in a broader perspective, having to put all other MDAs, that's ministries and agencies, to be part of this team to eliminate NTDs. We're looking at having to also develop a master plan where we have those that deal with finances to be part of it. Let's look outside the box of only NTDs, the silos things. We need to have the finance people understanding that once we are able to eliminate NTDs, about 15 diseases, that means, the health sector has gone very far in making sure that we make sure that everybody is well. When you have behavior change is another thing we need to still look at, where we've been working with Sightsavers on that. Moving from paper to electronic is key. You're monitoring people, persons, places, medicines. You're looking at a broader perspective. So I'm thinking that integration also, Ministry of the Environment, Water Resources, the wash sector, philanthropists in country. You heard one of the speakers in the last session talking about us looking in country, not only donor driven. We need to explore a lot of things. We need to also look at research. We're not paying attention to research. They answer questions we can't answer scientifically, and we can use that to be able to make decisions at the government level. The master plan is also key. We need to develop, which our country has started doing, looking at developing a master plan that involves all sectors, all stakeholders, people in environment, water resources, budget, philanthropists. New partners also coming on board is another possibility. We have CHAI, eHealth Africa, the ASR Africa in Nigeria, looking to come in to support NTDs. Also developing the master plan, looking at the SDGs, One Health, universal health coverage. Mental health is something that NTD family needs to look at. A lot of people have these issues. They're emerging, and we're working with CBM Global, even with Sightsavers, looking at the path of mental health, trying to develop a guide. How do you do that? A lot of people that come up with these NTD diseases go through a lot of emotional trauma. So we need to start looking at that as one of the next steps going on. The last thing I'll say, because it's on ending, I could keep talking. I know we're dealing on time. We're looking at the disease management area, IDMs. We focus so much on the 5 PCs. I know Ascend program had looked at the 5 PCs, but we're advocating to partners to look outside the box, because at the end of the day, one of the indicators that we will be needing for us to say we've eliminated NTD in country, e.g. LF, is the number of cases and how they're managed. So I think for me, this is looking at the different NTDs, approaching it from a different perspective for us to move towards elimination of NTDs globally. Thank you.
Thanks, Perpetua. Joy, can I turn to you? Your thoughts on the future and how we get impact and success going forwards.
Thank you very much, Tamar. As I listen to all the presentations, I'll just say as a next step, I think it's about sustaining the momentum in terms of the investments that have gone into NTD. And this is quite difficult in the context of economic crisis and instability and other forms of insecurity. So it's understanding that a lot has been invested into the elimination of NTDs, and a lot more needs to be invested, maybe in a different focus. Before now, in the NTD community, we were counting number of treatments that have been delivered. Now we're counting down to number of people who do not require any treatment because of the interventions that have come. So for me, that's the future. It's investing so much in assessments and trying to gather evidence to show that all of the hard work has gone into distribution of medicines in the past is worthwhile. And an element of the health system that we will need to strengthen if we are looking at sustainability of all of these efforts is the aspect of human resource for health. And in developing countries where the entities are most endemic, that system is also efficient in terms of human resource for health. And the focus should be on the communities and on the countries owning these programs and running them, even with these scarce resources available. So it's with training the community volunteers and helping them understand that this is a priority to them and their health system, and that they are able to contribute significantly in ensuring that we eliminate NTDs, as we say in Nigeria, for good. So this will involve a lot. I know that there's a lot of donor fatigue, but if we've invested so much, we might as well get it to the last line. So this end line requires a lot of commitment on the parts of researchers, on the parts of the government, on the part of INGOs, to make sure that we bring it all together. And like Perpetua said, if you want me to talk, I can keep talking, but I'll stop here for because of the time. Thank you.
Thanks so much, Joy. So David, finally, I'm going to pass to you. And I know you had a point from the last session, so maybe you could reflect on what you feel that the future needs, and then that point as well.
Thank you. Can you hear me?
Yes, I can.
Fine. Well, thank you for the session, and thank you for the organisation of this epic meeting. I mean, it must have taken a huge amount to pull everything together, and I've been privileged to work with the editors of the supplement over the last few months to try and put something together which I think will stand the test of time. Having said that, I just want to make a few points. I was going to comment at the end of the last session on people using the term siloed NTD programs. I actually reject this in the context of the fact that if you look at the global fund diseases, you can't find much more interventions that are siloed than some of the interventions for HIV, TB, to a lesser extent malaria, but and also coming back to other diseases in inverted commas, there's not much more siloed than polio and guinea worm. I mean, they have to be if we're talking about diseases, and people have done. I'm not suggesting we aren't looking at system benefits of these activities, but if you're to target an infection, you've got to know about it. And if the global community wishes to spend money on polio eradication, fine, but you can only do it through a relatively siloed approach. So I want to move away from that to reflect on what I think should be the priorities over the coming years. Obviously, we need to look and reevaluate as appropriate the WHO roadmap, which is an excellent document, and it points the way. But I think that we have to also recognize that we have to sustain what we have, which have generated significant benefits to 1 billion people a year over the last 10 years or so. That is some achievement. But we also have to remember that, as Phil has pointed out, that has been driven by extraordinary generosity of drug donors who sustained their contributions, in some cases long-term commitments. Merck obviously with onco ivermectin for as long as is needed. We have to keep those groups on board, and we haven't given them an adequate credit. I would point out also, in relation to the appropriate remarks that Joe Keating made, essential packages of care. All the products that are donated by the pharmaceutical companies, valued at between $2 and $3 billion a year, are actually within the WHO essential drugs list. Countries would have to pay for those if they weren't donated. I question whether that resource would be available. In the context of health system strengthening, there's quite a lot has already been published on this, but I would ask people to remember that there was a series of NTD papers that I edited in the Lancet in 2010, where there was a specific paper on health system strengthening by the Ghanaian group under Johnny Jaipong and Margaret Jaipong, which directly addressed this issue. And I have a slide in front of me which basically says you can look at the system benefits from these interventions. And we've heard some today about improvements in surgery in relation to hydrocele. We know about the strengthening of monitoring and evaluation systems, the value of surveillance which these programs have, the strengthening of the supply chain logistics in terms of drug distribution. Now, one thing that I wanted to add also was that I fully accept that countries have to have ownership of these programs. They have to decide for themselves what is going to be their priority. One of the things we did very early on in the LF program, working in Burkina Faso, was not to engage only the Ministry of Health, but also the Ministry of Finance. This has been mentioned. The Ministries of Finance are crucial. They have to actually be shown the benefits of interventions, whatever they may be, and the recognition that these benefits are going to, the financing locally is going to bring wider benefits to the population. But one thing that hasn't been mentioned is why these programs exist in the first place and why there was such advocacy for them. And that was poverty alleviation. These diseases drive people into poverty. They cause poverty. And this is a crucial issue. And I come back in that context to universal health coverage and the Sustainable Development Goals. We published in, I think, 2016, 2017, when the Sustainable Development Goals were published, a list of interventions against the targets which were identified in the Sustainable Development Goals, which all member states signed up to. Hunger, poverty alleviation was the top one. Hunger, health was the third, and NTDs were specifically included and mentioned alongside HIV, TB, and malaria in the health targets. The fourth one is education and the benefits which derive from NTD interventions in relation to education. The third one was gender inequality and the impact that the community-directed treatment movement has had in involving females in drug distribution has been remarkable. The sixth one is WASH, and we all know about the importance of WASH. And I'm going to come back to that in a minute. The other point I would like to make in relation to the SDGs are two or three other issues. One, urban issues. Nobody's mentioned the problems of developing appropriate interventions in very complex urban and peri-urban settings. 55% ish of the African population will be living in cities by 2030, which is an African Development Bank figure, not mine. There are issues of climate change and so on The final point about the SDGs is 17, and that is about the importance of partnerships. And I can't think of many organizations, interventions, and development activities which have demonstrated the strength of partnerships. And I think the NTD community is a fantastic example of that. Coming back to issues of the status of NTDs in the future. In 2015, Richard Horton, the editor of The Lancet, at a meeting that I was involved in London, used a term which I responded to a WHO intervention. Actually, NTDs represents a global pandemic. There are still 1 billion people who suffer from these conditions. And we have to bear that in mind in terms of our advocacy. We've all been subjected to the traumas of the COVID over the last 2 years. Actually, there are 1 billion people still out there with a chronic pandemic. They're not going to get rid of these conditions unless we intervene somehow. And I come back to one of the things that really strikes me as important here. And I always use the term Bill Clinton used, it's the economy stupid. No, it's transmission stupid. If we forget how these conditions are transmitted, then we lose the focus. And the point about this is that involves very often interventions which are actually not related to MDA. It's all about WASH, it's about education, it's about behavior change. And unless we focus on why people become infected and how they become infected, then I think we forget the underpinning biology which is driving these conditions. And on the top of that, I mentioned it in relation to black flies in northern Nigeria and the Sahel, the Guinea savannas. Climate change is going to actually have a huge impact on the epidemiology of these conditions. And the point about that is we don't have the resources, probably the insights, to respond quickly enough to the changing scenarios that we're going to be faced with. So those are just a few of the issues. And I will remind people in relation to poverty, the proportion of official development assistance which is spent on NTDs, and it headlined in a Lancet series that I mentioned earlier, only 0.6% of official development assistance for health was spent in 2010 on the diseases of the poor, which affect 1 billion people. Now, I claim that that represents a statement which demonstrates the inequity about distribution of resources in health. We still have 1 billion plus people who are in need despite the successes we've had. And we have to sustain the momentum. And I think we have to work on advocating for continuing NTDs as a health issue, notwithstanding the fact that policy changes, they should be included in every health package, essential health packages, because they affect so many people. But at the same time, we have to remember that they're biologically diverse, and we have to adapt our strategies to respond to that epidemiology. The final thing I'd like to say is that I'd like to be a realist rather than an optimist or a pessimist. And I think we have to examine very strongly our aspirations in relation to the elimination targets in some of these diseases for biological, geopolitical reasons. We mustn't set the bar too high because we're in danger of failure to achieve what we all hope we can. Anyway, I think that I've said enough, Tamar. Thank you for a very stimulating day. Congratulations to everybody who's participated. Thank you for inviting me. And let's go forward with optimism and realism, and hope that we maintain the interest of the country communities and the country programs, and congratulations to all those country workers, ministries, local NGOs, etc., who contributed so much to the success of the Ascend programme. It was absolutely critical that you were engaged. It's been a pleasure working with you, and I look forward to a continuing association in some way. Thanks.
Lovely. Thank you. Thanks, David. And thank you to everyone sharing their thoughts on next steps. And we've said many times this afternoon, we could be going on for many more hours with the issues that we've started to uncover and discuss together. There is one question in the chat, but from Sarah. Sarah, I'm going to refer you to Simon. Everyone who has a question that they haven't been able to ask today about the programme, sorry, excuse me, please do either contact Simon Bush direct if you have his details, or you can come through RSTMH, myself or Amelia, who I'm sure you've heard from in the last week, and we can pass the questions on, because I did want the chance just to say thank you to our panel, and also just to ask Simon to say a quick few words before I close up for today. Simon.
Oh no, thank you very much. What an excellent afternoon it's been, and thank you very much for keeping us to time and on schedule. I just wanted to say just a few final words, thanking the speakers, the facilitators of the session, and all the participants who joined us today. Thank you for being with us. Tamar, I wanted to thank you, RSTMH, Amelia and Eva for hosting the session and keeping it going, and thank you very much for the support that you've shown. Particular thanks to Susan and Danny from Sightsavers, who put the program together, did speaking briefs and all of that sort of thing. It's been an absolutely wonderful afternoon. Thank you. And just to say, I hope to see many people actually in person at the RSTMH annual meeting, which is being held in Liverpool next week. So back to you, Tamar, with many, many thanks indeed.
Thank you, Simon. So the last few seconds from me. I hope you enjoyed today. We'll be sending around a recording of the webinar and a survey. You know, we host these kind of events for our partners quite a lot. We always want to improve them, so your feedback is very important to us. And the last word really to the partnership, to the supplement. It's an incredible effort from so many people in so many countries that the work of Ascend has been delivered, and we've seen some of that in the supplement. And what we wanted to do at RSTMH in partnership with Sightsavers and other consortium partners is to really bring to life some of those great learnings, and in the hope that they can be shared across different areas of our work, different parts of our community, to make sure that we are galvanizing any efficiencies and important areas which can deliver impact for others as well. So please do stay in touch with RSTMH if you can. There'll be another supplement as part of this partnership coming out next year, and other activities, blogs and all sorts of things that are very accessible. So if you want to stay in touch, go to the website and sign up to the newsletter. Sorry. And we've got the link in the chat. Thanks, Amelia, again to the supplement. Please do spend a bit more time if you can. If you've not already read the supplement, have a look at those papers. Just are really, really fantastic and food for thought. So thank you all. Thanks for coming, sparing the time. I know it's been a fairly long webinar. It means a lot to us. And see you soon. Thank you.